I will speak in Arabic first, and then I will try to speak in English because we have some guests from outside of the country. بسم الله الرحمن الرحيم. نرحب بكم في المؤتمر الثاني للقدم السكرية بعنوان أزمة القدم السكرية طرق الوقاية والعلاج. المؤتمر الثاني للقدم السكرية عبارة عن قصة بدأت أحداثها بمنطقة القصيم ببريدة. أبطالها كان أشخاص محدودين وبإمكانيات جدا محدودة، ولكن الحمد لله تكللت بنجاح باهر للمؤتمر الأول للقدم السكرية. وبعد الانتهاء من الجزء الأول من القصة وبنجاح كبير للمؤتمر الأول وحضور أكثر من 15 متحدث و200 مشارك و5 شركات راعية، قررنا أن ننقل باقي أحداث القصة لمنطقة الرياض، ولكن تبنى إخراج الأحداث هذه المرة الإدارة العامة للمراكز المتخصصة بقيادة الدكتور عبد الله السهيمي. ازداد حماس الأبطال لإنتاج أحداث هذه القصة، وأجزموا بأن هذه الأحداث سوف تكون مختلفة 180 درجة عن أحداث المؤتمر الأول للمؤتمر القدم السكرية بالقصيم. أبطال هذه الأحداث اللجنة المنظمة واللجنة العلمية: الأستاذ عبد الله عربي، الأستاذ نسيب الحربي، الأستاذ محمد الباحوث، الأستاذ سعد الفايز. وشارك في إنتاج هذه الأحداث أكثر من 18 شركة راعية لهذا المؤتمر، وعمل على إخراج هذه الأحداث بالصورة المشرفة شركة الخيول الثلاثة. نترككم مع بداية أحداث هذه القصة للمؤتمر الثاني للقدم السكرية، وأتمنى أن تنال إعجابكم أحداث هذه القصة في خلال اليومين القادمة، وسوف تكون مليئة بأكثر من 40 متحدث من داخل المملكة وخارج المملكة، من منطقة الخليج، من الكويت، عمان، قطر، البحرين، العراق ومصر، سوف يشاركون خبراتهم وعلمهم في مجال القدم السكرية. يعتبر هذا الحدث من أكبر التجمعات لتخصص القدم السكرية. It's my pleasure to welcome our colleague and our guest from Saudi Arabia and outside the kingdom. And you are welcome in Saudi Arabia. We'll start our conference today. The first session will be the sharing experience in the Gulf region. It will be people from Qatar, Kuwait, Oman, Saudi Arabia, Iraq, and Masr. We want to welcome our moderator for this session, Professor Andrew Bolton. Please come to the stage to be moderating this session for the Gulf experience in diabetic foot. We'll start with our distinguished speaker, Dr. Khalid Idris.
Good morning, everyone. No slides? I didn't memorize my slides. All right, بسم الله الرحمن الرحيم. الحمد لله رب العالمين على نعمه التي لا تحصى. وأحد اللي طفيته. الإنسان ما يعرف نعمة قدميه إلا لما يبدأ يتألم فيها ويفقدها لا سمح الله. All right, are we ready? This doesn't count from my time, by the way, because I have no slides. I'm glad that I'm giving the first talk because I'm going, hopefully, to set the stage for the situation in Saudi Arabia, and I think it's going to be the same or worse in other Gulf and Arab countries. I'll give you numbers that are shocking numbers if I have my slides. So I think I know the first few slides. Always I start my talks with defining the diabetic foot. We always say the diabetic foot. This is a diabetic foot conference. The diabetic foot is a general term that I don't like. Okay? Okay, now we can start. So, and I'm going to come back to the definition. If we just look in Saudi Arabia today, our current population, this is the latest numbers as of 1 week ago, 37 million. We're the fourth highest in the world for the rate of diabetes for the age of 20 to 79. Diabetic patients age over 25 in Saudi Arabia is 4.5 million, okay? Let's just base off of that number, 4.5 million. I'm going to throw at you a lot of numbers, okay? So starting from in the beginning, if we have a prevalence, these are calculated numbers. These are not published numbers. These are calculated numbers. Very simple calculations. 10 to 15% prevalence of diabetic foot ulcers. From 4.5 million, that is 450 to 675,000 diabetic foot ulcers in Saudi Arabia. You know how big that is? That's huge. That's a lot, okay? Next. Neuropathy, about half of them, 2.25 million. I think the drug companies are very happy with these numbers. If we say peripheral arterial disease is 20 to 50%, depending on the studies you look at, you're looking at 900,000 to 2 million patients with neuropathy. Lifetime risk of diabetic foot ulcers, depends on what you read, 19 to 34. So you're looking at what I published in Jaridat Uqab, in a newspaper, years back, and I said 1 million Saudis are at risk for ulceration and amputation. And then some people told me, oh, you exaggerate. No, I don't. These are just facts that we have to live with. So at a cost of 25,000 riyals per patient, we're looking at 11 to 17 billion riyals. Most of the budget of the Ministry of Health, I think the number was 13 billion, is spent on diabetes in Saudi Arabia. So let's look at amputation numbers. We do not have official numbers. There are a bunch of few studies trying to give these numbers. But I calculate that we have 85,000 to 128,000 amputations per year. This includes all major and minor amputations. A part of the little pinky is an amputation, okay? We're not talking about just above knee or below knee. If we look at the US numbers, their major amputations is 154,000, but then their population is 100 times more than our population. Big numbers. Okay. Let's see published. This is a study that we published I think a few months back. And the critical point that we find is that 71% of ulcerated patients are in Saudi Arabia, in our cohort of over 1,000 patients, is a person, a male, who's 60 years old and have had diabetes for 18 years. This is the magic number that is an alarm for amputation. 43% of our patients used traditional remedies. Disaster. Dr. Hani likes this word. Disaster. 43%. Okay? 14% of these were told to use traditional remedies by a medical physician. Our doctors, our surgeons are telling the patients to use murr and sabr and honey and all those sorts of things. 77% infection rate with traditional remedies. There is no doubt about it. In our paper, we show a very strong relationship between infection, osteomyelitis, and cellulitis with the use of traditional remedies in Saudi Arabia. So that's something that we have to fight, and I'm sure it's the same in other Gulf countries. And of course, higher grade of ulcer. So, who's managing diabetics' feet, as I like to call them? Okay, so when I was talking about the definition in the beginning, I don't like diabetic foot. I like diabetic's feet, because diabetic foot means nothing unless you put more information to it. Diabetic foot ulcer, diabetic foot neuropathy, diabetic foot vascular disease. So please, in your charts, just don't try diabetic foot. That means nothing. It just means a human being who has a foot and is diabetic. We have about 23 diabetes centers. Each diabetes centers have a foot clinic in it, although we would agree all that they're very dysfunctional. We have 286 hospitals of the MOH, 164 private hospitals, 23 National Guard, 25 Ministry of Defense. All of those try, and of course, our center in Jeddah, which have become a center of, a tertiary center for reference, where myself, Dr. Hani, and Dr. Wajdi, and a bunch of other people work. So everybody's doing it, but nobody's specialized. We need more specialized centers. So my request of this delegation, of this group, is we must have a national diabetic foot program. And that's what I've been working with for a bunch of years, a lot of years. And it's still not happening. Maybe now that the momentum is going, we can have a national diabetic foot program. So since we're in Saudi Arabia, let's talk about Hajj. And this is something good to know about. About 2 million people come to Hajj every year. And these are people from the Muslim world mostly, and from the Arab world secondly. And these are the most diabetic patients in the world. So I call Hajj the biggest gathering of diabetics in the world. You have about 200,000 diabetics coming together in a few square kilometers area. So imagine the problems. And what causes the problems in Hajj in Saudi Arabia? It's mostly burns from walking barefoot and trauma. So we have several programs. These are volunteer programs that me and Dr. Hani work with. We have a bunch of people that we train before Hajj to go out and examine and triage and bandage the pilgrims in the field. This is not in hospitals, this is in the field. Okay? And this is what happens. Our kids, which I call the Knights of Hajj, boys and girls from all over Saudi Arabia, they go out and literally bandage pilgrims on the ground, on the floor. Okay? But they're very well set up. And I can't end without giving you good news, is that these guys are coming to Jeddah very soon. The lab is actually finished. I hope these are maggots. If you don't know what these are maggots. These are fly eggs. And then when the egg hatches, then we have a maggot. The maggot is great for creating ulcers. The lab is finished in Jeddah. It should be operational soon. I hope we have our first maggot 1st of May, and 1st of June we treat our first patient. Anybody wants maggots for their patients? Yeah, good. They'll be available in Jeddah. By the way, that's not caviar, that's fly eggs. All right, so menu, bugs and pus, blood debris. So they're saying to each other, enjoy it while you can. You should see what you get when you grow up as a fly. Thank you so much.
Thank you very much for an excellent talk and a little English humor as well. I would say that, to remind you, until recently I was president of International Diabetes Federation, and our last atlas was published 2 years ago, and we reported an increase in the global prevalence of diabetes of 16% in 2 years, 16%. We're facing a global epidemic. And I fear that it's going to get worse after the COVID-19 pandemic, and we're seeing some evidence of that. And diabetic foot problems are extremely important, and as you rightly say, carry a very high mortality and morbidity, and must be taken serious. Indeed, they're probably worse in terms of outlook than many forms of cancer, especially if you're on dialysis. So that was a very nice introduction, and we move on to the second, and we're moving to Kuwait. It's a pleasure to introduce Dr. Nasser Al-Mahdi, who trained, he's a foot surgeon. And my guess, it says he trained in Madrid, that he must have trained with my friend Lazaro Martinez, Jose Luis, who I was just emailing the other day. He's professor of surgery and podiatric surgery in Madrid, and he's introduced evidence-based guidelines into managing diabetic foot disease in Kuwait, and has improved, which it says improved, I presume that means reduced, the major amputation rates in Kuwait. So he's done a lot of good work on the diabetic foot, and we look forward to his presentation. While we wait, it's certainly we've got a major problem with diabetic foot ulcers. In a recent review with my former PhD student David Armstrong in JAMA, we've just published some horrendous data in terms of the prevalence of diabetic foot ulcers, which sadly continues to increase. And sadly, the Middle East of course, there's a very high prevalence of diabetes and, as we've just heard, foot problems. So, Dr. Ahmadi, please, from Kuwait, let's see what's happening there.
Hello, everybody. I really do thank this organizing committee for inviting me to participate in this diabetic foot presentation. Dr. Idris, what I usually say in Kuwait, definitely in Kuwait, diabetic foot is an orphan disease. مرض يتيم. Nobody wants to ما حد بيتبناه. So the main issue is that we are facing people who do not believe in diabetic foot disease. Or in other words, they do believe in diabetic foot disease, but they're just giving a blind sign to it. They're not looking at it seriously in a serious matter. And this issue with the prevalence of diabetes now is going to create a lot of havoc. So when I went to study, so when I finished my Kuwaiti board in surgery, I decided to go as a fellowship in diabetic foot. All of my colleagues came to me and said, what are you doing? Why are you going for diabetic foot disease? The main thing is, they all went, all of my colleagues went for bariatric surgery because that's where the money is. Nobody even thought about doing diabetic foot as a fellowship program. So when I came back, if I didn't have the proper help from the head of my department and some slight officials in Kuwait, then what I've done in my hospital would not have occurred. So currently now I'm going to show you my experience in Kuwait of when I first did according to what I could claim, and I could proudly claim, the first diabetic foot unit in a government hospital, which is done in the Farwaniya hospital. So we established it at 2018. I finished my diabetic foot fellowship at 2017. And it consisted, this is what we consisted of now, which is one consultant, which is me, 3 registrars, 2 assistants. I had 3 trainees, and a permanent nursing staff. This is very important to have a permanent nursing staff. This is what you see as now. But initially when I started, it's only me and a registrar. That's it. Not even a nursing staff. So starting from there and trying to convince the Department of Surgery that diabetic foot is something which should be taken care of and should be really you should really concentrate on. At first, they did not even consider it. They thought that this is something not to be discussed with. So here I'm supposed to have a picture of my clinic. It's a very small clinic with 4 pediatric chairs. And we usually see initially nearly 40 to 50 patients a day. And each of them are being dealt with according to international guidelines. So this is it. I'm supposed to see if the video actually works, but let's see. So anyways, I follow the International Working Group for Diabetic Foot. This is the guidelines that I followed, and this is what I implemented, and I tried to implement into the center that I had. And my main goal was limb salvage surgery. This is the most important part. So what are the things that I really found initially? It's unnecessary. What you're doing is time wasting. We do not believe in anything called diabetic foot. I mean, what are you going to do? This is the first thing that I got. So what? You're going to get a diabetic foot, and then what you're going to do? Admit him, do some debridement, and then you're going to discharge? It's not as easy as that. Trying to actually give them the picture that diabetic foot disease is really something major, and that they really should be thinking about it and grasping the idea of diabetic foot disease and trying to tackling its problems. I mean, with the prevalence of diabetes now, you said Saudi Arabia was the 4th, Kuwait is the 2nd. So could you imagine the number of patients that we have? Nearly no family in Kuwait, no Kuwaiti family doesn't have any patient or anybody from their family who are not diabetic. This is a norm now. So could we imagine what would happen? So after 1 year of establishing a diabetic foot unit, I've been hearing these talks. What are you doing? What of them had underwent amputation? So as you can see here, in 2017 and 2018, the number of patients who were admitted, who had underwent amputation, 18. That's in 1 year. After the establishment of the diabetic foot unit, you could see right here at 2018-19, 4. So in other words, and not even that, you could see the number of visits to the clinic. From 2017, it was nearly 4,000 per year. But when we established the diabetic foot unit, it's about nearly 7,000, more than 7,000 patients. So you could see the correlation here that we had reduced the amputation rate, major amputation rate, by 90%. There is something wrong. And this is in one hospital, one major hospital. We have 5 major hospitals in Kuwait. So I would assume the same norm would be happening in any other hospitals. So in other words, people are getting amputated while they're not needed to be amputated. This created a lot of havoc in Kuwait. This statistics had reached the Ministry of Health, and they realized that there is something wrong. So it's by doing this that we actually do a change, that we create something for at least for somebody at the higher ups to actually see that there is something wrong, and we could deal with something which is very important. Now, I'm not showing off. I'm not saying that I'm actually a muscular guy and that I am the best diabetic foot surgeon there is. I'm following guidelines and I'm following protocols. And through these protocols, these are the results that I got. It's not magic. It's pretty much easy. What are the main issues? Offloading, currently non-existent. With the traditions of a Kuwaiti gentleman, I do believe also in Saudi Arabia, everybody is nearly walking barefoot or with sandals or slippers, and with no care and know-how of how to take care of their foot, even after when developing diabetic foot ulcer. So it's socially unacceptable. And according to them, and yes, it is, that the offloading modalities that we have in Kuwait is pretty much expensive. This is one patient who presented to me in the clinic. He came in with a piece of bag wrapped up on his leg. And this is just recently, after establishing this for now 3-4 years. And it's something which is definitely not acceptable. So I tried to use a modality. This is a life-saving thing that I got. It's pretty much cheap, nearly 7 KD, which is probably 80 riyals or something to that. And it has a rocker bottom. And for most of my patients, I tell them, if you do not, because the government do not provide this, but I tell them, look, if you do not get this, I'm not gonna see you again. I'm trying to force them to actually get it. Because without offloading, as you may know, the ulcer will not heal. Definitely will not heal. At least let me have something. Let me have something to offload them. So what I'm using is this. So what are my current issues? That I really do have late arrival of diabetic foot patients and really challenging and complicated cases, which we could simply reduce the rate by implementing a diabetic foot screening protocol nationwide. And try to get this through the Ministry of Health is pretty much difficult. What are the issues that I have? Multidisciplinary team concept is not being implemented at all. Everybody says that diabetic foot is diabetic foot. You don't need to have an orthopedic on hand. You don't need to have a vascular surgeon. If you need anything, just call us and we could see the patient. And usually it's your job now, it's not ours. They don't believe in having to take care of the patient as a team. So what I do consider, at least in my institution, that what I need is a vascular surgeon, plastic, orthopedic surgery, and an endocrine. Now we've implemented the vascular, the plastic, and the endocrine, Orthopedic part, even though we have a department, but they're not willing to help in anything, even with reconstructive surgeries. So this is like one of the challenging cases that I got. And the first thing that I received was, well, when I got this patient, is below knee amputation. As you can see, this is the calcaneum bone which is being protruded out of there. So I took the patient, even with all of my colleagues, all of my consultants, all of my mentors told me, Nasser, what are you doing? For the hell, please, don't waste time, do a below knee amputation. But I proceeded. This is one of the first cases that I had, which was really challenging to me. So I proceeded and followed the guidelines. So initially I did a proper calcinectomy, and after some time, some granulation tissue with proper negative pressure therapy. And I did for her some multiple debridements. And then I applied some stem cell therapy after that. As you can see, the wound is pretty much undermined at the edges, but there is some good healthy granulation tissue. It's beefy red. This is what I call a beautiful wound. This is, to me, this is something which I would hang on my wall. After some time, as you can see, that there are some receding. So I'm not just going to waste time. You could see total difference between the first picture and the last one. And the patient is now walking, and she's pretty much happy, and she has her foot. This is another case of necrotizing fasciitis, which I'm going to discuss also in detail, but this is the first admission that, from the first admission, he's a porter in an airport, and his line of work is that he needs to walk on his foot. As you can see, the first thing that he was admitted with was a small abscess at the dorsum of the foot. X-rays showed to the left there, showed that there is some air. So I proceeded to do a CT. As you can see, the left foot reaching up to the thigh, reaching up to the cuff, there is some air. So we diagnosed as necrotizing fasciitis. In surgery, while I was doing the debridement for this patient, the amount of doctors who came to me and said that you are wasting your time was really devastating. So we proceeded with proper guidelines and proper debridement. I did probably 5 to 6 debridements for this patient in a near of probably 3 weeks or 4 weeks duration. I'm not going to waste any more time, but I applied something called a fish skin therapy. It's from Kerasis, and it's an amazing product. And this is all done now on an outpatient basis. As you can see, look at the wound. Simply, totally resolved. And the patient is now walking and back to work. So, thank you.
Nasser, wonderful work in Kuwait, mashallah. It's great to listen to different experience from different countries. Now we'll take you outside the Gulf region. We'll go to Egypt. We have to welcome Professor Wala Khalifa. She's a professor of internal medicine, endocrinology, and diabetes at Asyut University. Please welcome Prof. Wala, and let us hear the experience in Egypt.
Good morning, dear professors and colleagues. Actually, it's my first time to be here, and I express my great and deep gratitude to all the organizing committee to participate in this big event. Also, I'd like to thank Professor Andrew Bolton. He's the father of diabetic foot and was the president of the IDF, and we learn more from Andrew Bolton. He came to Egypt many times and train us how to proceed with diabetic foot. I think my question is, why diabetologist attacks diabetic foot? And why females also attacks diabetic foot? I think diabetic foot is aggressive for female. I like to male. Also, diabetologists, their main concern is about glycemic control and how to control of diabetes and prevent diabetes complication. But actually, we stick to the patient many times. We see the disaster of amputation, how it can affect the patient lifestyle, how it affects the patient quality of life with depression and cardiovascular mortality. So our main mission is to delay or prevent the amputation as we can. The presentation? Okay. In Egypt, still we have 2 diabetic food centers, which is, the first one was in Mansoura University under supervision of Professor Hanan Gawish, which is a professor of endocrinology and diabetes, and she represents Egypt in the International Working Group of Diabetic Food. And the second diabetic food clinic or unit was in Asyut University, which is my university in Upper Egypt. I think that, yes, we will start our presentation. This is Egypt, and this is Luxor. You know, Luxor, one of the governorate in Upper Egypt, and it is very treasured in monuments. And this is the beginning of our story. This is my agenda. We will explore the magnitude of diabetes and diabetic food problem and identify diabetic food journey in Egypt. And I understand why diabetologist attacks diabetic food clinic and assess obstacles we facing and finally future direction. Actually, Egypt is one of the top 10 countries in the prevalence of diabetes, which reaches about number 9 in 2019, and this will be increasing up to number 8 and will be number 7 in 2045. So we're facing a high prevalence of diabetes. In Egypt, in 2011, we reached about more than 10 million people with diabetes, and we do a national campaign for early screening and detection of diabetes, and this number reached to about 15 million people with diabetes. The big problem is the high prevalence of undiagnosed cases, and Egypt is, represents number 5 in countries with undiagnosed people with diabetes. In Egypt, we face a healthcare service problem, and we're facing a higher rate of overpopulation, which we may reach up to 1,051,000 by 2050. And we are the first Arab countries in the number of population and the third in Africa. This may mainly cost expenditure for healthcare services, and this is face a very big problem in Egypt. Regarding the prevalence of diabetic neuropathy, Egypt was the second country after Saudi in the higher prevalence, which exceeds 2/3 of diabetic patients represent with peripheral diabetic neuropathy. And we do a food screening to assess the risk categorization of patients in Asyut University in 2022, and we found that about more than 50% of cases have food at risk, with ranging from mild risk, moderate risk to severe risk. Also, Professor Mamdouh Nahas in Mansoura make a study about the prevalence of diabetic foot ulceration and the risk factors which affect diabetic foot ulceration. And we see that lack of education represent about 93% of cases who have diabetic foot ulceration. So education is very essential to prevent a diabetic foot problem, as I think it is a preventable complication. Another study shows the prevalence of diabetic foot ulceration, and we see that diabetic foot ulceration prevalence exceeds 70% in people with diabetes duration more than 15 years, and this is a very high prevalence of diabetes. We studied the foot care analysis and the risk of foot ulceration, and we found that all patients with foot ulceration and about 78% of people with foot ulceration have lack of foot care. So we all agree that education is very essential from the beginning. Foot care is very essential from the beginning. So this is the main mission. So how our journey begins in Egypt? In Egypt, until 2000, diabetic food services throughout Egypt, especially in rural areas, were very limited. And they are managed by untrained healthcare professionals. And the compounding problem was the lack of sustained infrastructure of diabetic food management, trained personnel, and there is up to now no formal pediatry services. There were no structural educational programs established for training healthcare professionals and to manage diabetic food complication effectively. Also, there is no identifiable specialist service infrastructure to support or train clinicians and other healthcare professionals to care for people suffering from diabetic food. So we have a problem with healthcare professionals, with patient awareness about the food care. So we started in 2010, participate in step-by-step project. Step-by-step project, which is a big project, supported by the International Diabetes Federation. Mission was to train diabetic food, so healthcare professionals to manage patients with diabetic food. This step-by-step project began in Tanzania and then in Egypt, and they trained about 15 doctors with different governorate to establish a 15 diabetic food clinic in Egypt. And we participate in this step-by-step project, and this was the beginning of our establishing of diabetic food clinic in Asyut. And the first diabetic food unit in Egypt was in Mansoura, under supervision of Professor Hanan Gawish, Professor Mamdouh Nahas, and Professor Manal. They are very, very qualified and have all services starting from patient education, awareness, up to management of advanced cases of diabetic foot ulcer, shark foot, and what else. And they are the beginner of diabetic food unit in Egypt. Asyut University, this is my university in Upper Egypt. We start to build a diabetes and endocrinology center in 2010, and this center contains many clinics, starting from diabetes clinic, clinic for education, clinic for prevention of diabetes, clinic for gestational diabetes, and also a clinic for obesity, for thyroid dysfunction. And we have our diabetic food clinic. We have 2 clinics of diabetic food, one for management of cases, one for screening for cases, and one for food dynamics and plantar pressure assessment to offload diabetic food. This is my team in diabetic food. I am a professor. I have 3 lecturers and 3 assistant lecturers in my team. What is mission as a diabetologist? First of all, we're focusing on patient education, and we do many patient materials education, starting from educational material like by words or by something drawing, as we have some people irritated and they don't read what is called. So we do many draws to analyze the education. Education starts from nutrition, education about how to inject insulin, what is the sites of insulin injection, how to deal with high blood glucose, with lower blood glucose, and also we have a diabetic food care education, and also we have a very important brochure about what is the food at risk, which is very essential to learn your patient and your nurse what is the food at risk, how patients seek medical advice, when he starts to seek medical advice, and what is the problems of his feet. And this is make many pictures of food at risk to simplify this to our patient. Also, we encourage the food care and make a food care brochure, and the medical companies support us for this. Education of the patient, it can by 2 ways, either individualized like this, or we can do mass education to all people with diabetes about diabetic food problems. Also, we take a focus on nursing, as a nurses is a very essential to pick up early cases of diabetes. So we do many nurses education program regarding education and food care, and also how to detect food at risk, and how to manage early cases, how to dressing, all of these we do. The third step was physician training, as we need more and more physicians trained to what is diabetic food. As diabetic food definition mainly changed from several years, and in the last there was diabetic food means infection, amputation, what else, but now there is food at risk, many food at risk earlier before starting to do amputation and and before to be severe. Physician training, we do regular workshops in different governorates, and about 300 physicians in Asyut now are well trained regarding how to deal with at-risk food and when to refer, and we arrange annual conferences. We educate the physician how to detect the at-risk food and how to screen the food, also how to offload the food and different methods of offloading, and how to dress the food ulcer and what are the suitable food dressing. And also we have advanced hands-on workshop to how to deal with pre-ulcerative lesion like callus, bully, and how to do debridement. We started to educate the patient on orange how to do callus removal and corn removal. Then we try to do in the patient. We do many workshops during COVID. We do many virtual meeting by many professors, and we have Dr. Abdullah from Saudi, also Professor Hari Krishna from Asia, and Professor Solomon Tisfay from UK, who tell us the magnitude of the problem of diabetic neuropathy. Also, we have many colleagues from India to share experience about diabetic food problems. Also, we have many conferences. We have 5 conferences in diabetic food, which was in different governorates in Upper Egypt, Asyut, Luxor, and Hurghada. Then we started to announce the word about our work. This is by participation in the diabetic food study group. Also, we have our talk in ESD in Berlin, and also in the IDF 29. And we share in some national campaigns, like to detect early cases of diabetic neuropathy. We have many researches about diabetic foot recurrence, which reaches about 60% of diabetic foot ulcers recurrence after 1 year. Also, we have research about the BRB and the offloading modalities in Egypt, and fungal infection in osteomyelitis, and the new era in the fake latex to inhibit the growth. Now, what is the clinical setting? In the clinical setting, we do food screening, and also we management of pre-ulcerative lesion. Also, we take care of ulcer, like debridement, dressing, and offloading. We do stem cell therapy in many different ulcers, which have marvelous results. Also, we do application of platelet-rich plasma, which also have marvelous results in wound healing. We deal with infected ulcers like this heel ulcers. We delay the concept of amputation somewhere. Also, this also infected ulcer, and they take the decision of amputation, but actually they completely healed. As you see, we do VAC therapy also to big raw areas, and we care of active Charcot food by do total contact casting and walker for chronic Charcot, or refer to orthopedic surgeon. We're facing still obstacles as there is no governmental funding. Also, lack of awareness to the need of food care, and few professionals with an interest in the diabetic food. Also, non-existing pediatric service, and the long distance of patient to travel to the clinic, and delay among a patient in seeking medical care, or late referral of the patient to specialty, and lack of awareness. My future direction, this is my last slide, is the only way to move forward is educational program, and I think educational and early detection is the prevention of all diabetic food problem. Multidisciplinary, we are now in interdisciplinary approach, but we need multidisciplinary approach, and early detection is very essential, and encouraging more patient campaigns. Thank you.
Thank you. Thank you very much. It's not on. Thank you very much for an excellent overview. As you say, I've had the pleasure of visiting Egypt, and indeed some people have been to my unit, and I know how much good work you do and how many foot ulcers you have. So thank you very much. Our next speaker from Doha is going to be online, but he's not with us at the moment because he's having some internet problems. So we're going to move on to Bahrain and introduce Dr. Mohammed Hatem. And he trained in Ireland, the beautiful country of Ireland, I think in Dublin. Yeah. And then he also did a rotation in neurosurgery there, and he's a surgeon. And he went for a fellowship in foot surgery again with my friend Jose Luis Ladres Martinez. in Madrid. And he's going to talk to us about the situation in Bahrain. Thank you.
All right. Good morning, everyone. Thank you for, first of all, the committee for invitation, and I'll talk about our experience. So, diabetic foot in Bahrain is still we're way behind compared to other Gulf countries. So, I went for my fellowship with Dr. Nasser, and we have no idea about diabetic foot like treatment. The first week I went there, like the Professor Martinez was asking like, well, you're here now, what you see, what we're doing, what exactly compared to Bahrain? I was embarrassed, but I don't know what to say to him, so I told him, like, honestly, not even 10% what you're doing. So then he said, like, oh, what, you doing amputation? So, yeah, amputation for everyone. And then we're going back to, oh my God, all these feet can be saved. And the easy thing, like, we're doing amputation. And when I came back, I was trying to fighting with the organization, like okay, with this, I needed support regarding diabetic foot clinic. So okay, no, start your clinic, but I start from zero. No dressing. They were doing betadine and hydrogen peroxide and anodine. No nurses. No one know about diabetic foot debridement or nothing. So one clinic, every daily clinic, one bed, and one not even nurse, practical nurse. So you have to struggle, and. It took me time to train all the nurses, like about provide the guidelines and support system. Now in Bahrain, we have complete wound care unit in King Hamad Hospital with hyperbaric with 15 certified nurses. In my hospital, we have daily diabetic foot clinic, and still we have I have 4 or 5 beds daily clinic with nurses, but they are not wound care nurses, so I have to teach them. Like I have to be like on top of them, like in every case. Yani. I have my podiatry, and we're sending more nurses for wound care training, and plus that, still we're lacking a lot of stuff. We need support. Like we're not asking recruiting more diabetic for surgeon or more podiatry, and then what they told me, like, well, we cannot hire someone to do just a debridement. So I told them, I'm just a debridement guy. That's my job. That's why they know about diabetic foot. It's just, this guy gonna do debridement and 2 amputation. That's their job. It's not gonna cost effective or save the feet. No, he's gonna do debridement. So we're still struggling with that area. And okay, I'm just gonna move on. And I'm not. These are all things we know. Just I'm not gonna drag with that because just for the sake of time. So introduction. A diabetic foot is a chronic disease of increasing incidence worldwide. And the prevalence in Bahrain still we are high in 40.7. Poor controlled diabetes cause late complication, as we know, like cardiovascular retinopathy, nephropathy, cerebrovascular, and neuropathies. A major public health problem causes economic burden in family and health system, and leading cause of admission and mortality. Patient diabetic foot also suffer from disability, reduced mobility, difficulty performing daily activity, which will cause adverse physical, social, psychological effect on health system and quality of life and general well-being. So, quality of life. Patients with diabetic foot also experience a wide range of negative feeling, including anger, fear, and depression. With those will also said were worried of fear for amputation and fear of major amputation may be worse than fear of mortality. Even with ulcer healed, patients live with worries, fear related to increased risk of recurrence of ulcer. Patient with amputation but were also free had significantly higher quality of life than with persistence also without amputation. So healing also such better quality of life. So majority of Bahrain, once they have diabetic foot ulcer, so they have fear mortality. They fear their life is over. I had one case 2 months ago, he had small ulcer in plantar surface big toe, talking about 0.5. He's a fisherman. The moment he entered the clinic, he said, "Oh, doctor, I still my boat. My life is over." Ulcer healed. He bought the boat. He had recurrence, he sold the boat again. And the circle moved on and on. And I told him, it's just a psychological effect. That's the problem. So, and we saw high quality of life in patients who were employed, higher education level, and single. So it's been suggested that focus on conservative management patient attempt to reduce or delay amputation can lead to increased suffering and thereby lower quality of life. There's a huge association between education level, employment, quality of life seen, and demonstrate poor quality of life score and unemployed patient with diabetic foot ulcer. There's evidence that employment can be markedly affected by diabetic foot ulcer, where 50 to 80% of patients were unemployment due to either early retirement or unable to work with the existing foot ulcer. So again, my emphasis, like in this lecture, about prevention. That's our problem. Like, okay, we have, for example, now we're on cuffs. We have great minds here with, talking about diabetic foot, from complication, from vascular, diabetic for surgeon, podiatry, advanced technology, but still the amputation rate is still increasing. And that's what we have to ask ourselves, like, okay, the technology is better, the education better, the training is better, but why we have still the amputation rate high? Even in Bahrain, we have a huge problem in prevention. No one comes to the clinic, no one comes to the screening, and when they come, it's late. They come with disaster, very bad infection, and they want me to do magic. I'm saying, like, how can I do magic with have infected gangrene up to your ankle? And the only solution now here, you just amputate to just improve, to control infection. But, and then they go and shop around, and they come from now 4-foot amputation to below knee amputation. That's why we have a huge rate of amputation still in Bahrain. Risk factor, again, as we know, the peripheral vascular disease is a risk factor. Still, there's no screening program in Bahrain. And even I told the vascular surgeon, okay, we have a lot of cases of peripheral vascular disease. Why we don't do screening? It's just a simple ABI. You don't need much. A patient comes with purely diagnosed diabetic or claudication or just a follow-up in the clinic, just a screening program. So you're going to pick up a lot of cases. It's why we have to wait to have patient have gangrene and to do a lower limb angiogram. And then you do toe amputation or debridement, and you just move on and on. And recurrence rate high. If we do the screening program, it's easier. And what he told me, well, I don't have staff. No one who's going to do your screening program. It's yes, I know I'm with you, but with lack of staff. That's what we're short of. So prevention. Again, I'm going to emphasize about these issues. 50 to 85% of all amputation can be prevented, and prevent diabetic foot ulcer was found to be cost-effective and increasing knowledge by awareness of self-care of foot among diabetic patients. Primary prevention methods such as health education play a key role in managing individuals suffering from diabetes, although the epidemiological studies shows high prevalence rate in diabetes in Arab countries. The control of diabetes is still poor, and complications of diabetes are common. Older age, poor judgment control, lowering duration diabetes, all these are risk factors of diabetic neuropathy. Risk of neuropathy, PVD, is higher among diabetic patients in Bahrain, and the implement strategy for prevention, early detection, appropriate treatment at the primary health care urgently needed. Early detection, appropriate treatment, diabetic foot ulcer could prevent 85% of all amputation, and by just a careful inspection of diabetic foot on a regular basis, along with health education. Family physician have leading role in earning a patient with diabetes receiving optimal care for skin ulcer. However, several studies found that foot examination are infrequently performed in primary care physician on diabetic patient, and feet hospitalization and diabetic are inadequately evaluated. Large proportion of diabetic patients have neuropathic complication, and therefore substantial risk of developing foot ulceration. Important risk factors in diabetic neuropathy include poor judgment control, and as you can know, so we need a strategy to reduce the risk of neuropathy in diabetic patient. Our population must be implemented. So a few points, and just I'm going to summarize. So what we have to do, again, prevention. More campaign regarding diabetes, health education for all the physician and patient about diabetes and diabetic foot ulcers. We need to control its factors, a screening program, easy referral pathway, guidelines to implement, and follow-up plan. And above that, we need to change the perception of diabetic patient about the diabetic foot clinic. When they enter in Bahrain, the perception diabetic foot clinic is amputation clinic. So that's the moment they enter my clinic, oh, my foot's going to be amputated. That's their perception. So if we change this perception, we're going to see a lot of patients earlier, like presentation, like it's even a simple ulcer or just a neuropathy. I don't see them. I see them when they have a gangrene or infection or very bad infection. That's when I see them in the clinic. So that's why, like, I'm suffering with these cases. And I said, where were you from the beginning? And so we have bad reputation. That's diabetic foot clinic. It's amputation clinic. Even during Diabetic Day, we have in November, Noor was there. We had full campaign diabetics in Sif Mall, like in Bahrain. I had small booth for diabetic foot. Imagine 8 hours I was sitting there. How many patients I saw? 4 patients. 8 hours, 4 patients. I see them coming. They go from endocrine to nutrition to measure their weight, all that. When they pass my booth, I told like, okay, come, we're going to educate you. So no, thank you, our feet is fine. We don't need to amputate. And they move on. Simple education, they don't want to listen. So how are you going to change that? Even when we do angiogram, we just train people more and more, but you have huge obstacle, huge defect in prevention. The people perception still about diabetic foot clinic, it's not there. So regarding treatment, what's these 5 factors you have to ask this question you have to ask ourselves, and what's our obstacles? So for example, patient-related factors, these are our obstacles: cognitive challenge, difficulty understanding diagnosis and treatment option, distrust in medical field, mental health stressor, concern about stigma of the diagnosis and diagnosis acceptance. Condition-related factor, disease severity, impact quality of life, history of previous complication, difficulty with healing, comorbid conditions. Healthcare system, what's our obstacles? Staff burnout. I'm the only one in my hospital doing diabetic foot, so I'm every day on call and I'm doing all the debridement, all the amputation. No one going to do that. So if I'm going to take 1 week off, everything stop. So you're going to hold all the cases till I come back. So when I come back, you saw disasters. Infection was there all the time, and they kept it till when I come back. Perceived length of patient, clinical contraction, absence of support system. Therapy-related factor. So you have to ask yourself when you treat the patient, complete treatment, frequency of treatment, side effect, and pain associated with treatment. Patient concern, patient always a focus. Put the patient up put the focus on the patient and their wishes. Make a clinical experience more of collaboration than instruction only. So that's why I emphasize, even my junior residents, like, discuss the case with the patient. Tell them what's the plan, imagine, what's their expectation. You have to know what's their expectation. Some of them, they want to, like, so I will, instead of doing below, I will live with a chronic wound. Fine, respect their wishes. What's our goal of care? Have a patient goal of care been discussed? Do they align with current treatment plan? Can this wound be healed? Do this intervention meet the patient goal of care? Is it palliative wound? So, in a summary, 3 points. Prevention, prevention, again, I'm emphasizing prevention. Patient center of care. Teamwork. Discuss the case with your colleague. Respect your colleague. Leave your ego away. Don't go and fight with your colleague. So it's a teamwork at the end. So I'm just going to give you one example. This 51 years old male, multiple comorbidity, 51, imagine, this is 51. Diabetes, hypertension, ischemic, he presented ischemic patch anterior compartment, so, and complete neuropathy from the knee down. No peripheral pulse, Doppler signal by obstruction on PT, and no Doppler signal on anterior dorsal pedis. So admitted, taken by vascular surgeon for lower limb angiogram, the anterior tibia completely occluded, the only peroneal and posterior tibia. Post lower limb angiogram, within 2 days, the patient complained mild discomfort. Urgent ultrasound, big abscess, 30-50, so taken for extensive debridement and evacuation abscess. And next day, he had frequent debridement, even with plastic surgery, so debridement with negative pressure wound therapy. As you can see, the whole the tibial bone was exposed. So continue with negative wound therapy, and as you can see, the progressive healing. The bone now was covered, but as you can see, the bone of the dorsum of the foot, on the midfoot and headfoot was still exposed, necrosis. So debridement was done, and patient was there for almost like 6 weeks for long-term antibiotic for osteomyelitis. But unfortunately, the conservative measure was failed, and the bone was getting necrotic. So I offered the patient a chopart amputation and reconstruction. So chopart amputation, negative pressure, and then plastic surgeon taken for skin graft. It took us a long time, and at least the patient will appreciate, said at least you avoid from above knee to just a chopart amputation. A lot of the vascular said, just you're wasting your time. Just do above knee and get it over with. I said, no, let's give him a chance. That's something, I know it's getting frustrated. I know it takes a lot of time, but keep kicking, keep progressing. respect your colleagues. Don't fight with your colleagues, because these are teamwork. They're going to help you around. If you're going to fight, no one going to be there. Okay, thank you.
Thank you very much indeed, and I hope you don't face too many disasters when you go back from here after 2 days. Thank you very much.
I hope so.
So we're again still waiting for Dr. Talal from Doha. So we're going to move on to the next speaker, and that's Dr. Hussam Yunus, who's chair of vascular surgery at the Cleveland Clinic, Abu Dhabi, United Arab Emirates, and strongly connected with Cleveland, Ohio, with the Case Western Reserve University. He's a vascular surgeon and is very active in diabetes research, an interest in endovascular surgery, dialysis access, and all the important things that, sadly, many of our people with diabetes require. Over to you, sir.
Assalamu alaikum, and thank you for this nice introduction. I'd like to thank the President, Dr. Hani, and the organizing committee for this invitation. As you heard, I'm a vascular surgeon, and okay. Moving from here? Okay, so we have to use the clicker. So I have nothing to disclose other than I have passion for limb salvage, as you will see. I was asked to prepare a 20-minute talk, but I think for the sake of time, I have to go through some of the slides very quickly to go through the whole material. I'm going to start with talking a little bit about peripheral arterial disease, which we abbreviate with the PAD, which what we refer to usually is atherosclerosis of the peripheral vessels. And it's estimated about 200 million people worldwide affected by the peripheral arterial disease, and those patients are very high risk of major cardiovascular and major acute limb events. And comorbidities like diabetes increases their thrombotic risk. How we're doing in UAE, over 1 million people are living with diabetes in the UAE, placing the country 15th worldwide for age-adjusted comparative prevalence. And we would like to know for the first and the highest buildings in the world, but we don't want to be known for this. And very common complication of diabetes is developing, as you know, foot wounds and peripheral arterial disease, which in combination can cause gangrene, which is a sequela of amputation. Why amputation is bad? You heard a lot about, let's go for the amputation. Major amputation can cause economical burdens because it causes disability, requiring long rehab, expensive prosthesis, reducing the workforce, especially in young population, and diminishing the quality and life expectancy of the affected patient, which affects everyone, their family, and the country. So in line with the growing diabetes prevalence, there's always demand for limb salvage program, and it's rising. So the peripheral arterial disease comes in 3 stages: the asymptomatic, the intermittent claudication, and the one that we most deal with was the CLTI, critical limb-threatening ischemia, under which lies the rest pain, non-healing ulcers, tissue loss, which causes gangrene and necrosis. And if you look at your right-hand side, you'll see the distribution of PAD based on morbidities. But if you look at your patients, how many of your patients have all these morbidities? So that means the peripheral arterial disease is really affected in diabetics. And I just want to give you a quick review about the natural history of PAD in its lightest form, the intermittent claudication. The risk of amputation is 4% in 5 years, which is low, and that's why we treat them medically when they're claudicant. But if you look at the right lower corner, 1/3 of these patients will not be with us within 5 years. And 70%, the cause of death is cardiovascular events. Because these patients, symptomatic PAD patients, face up to 6 times greater risk of death from cardiovascular disease, including MI and stroke. So how do we treat it? Quickly, by smoking cessation, controlling the lipid, control the glucose, control blood pressure, and start them on some antiplatelet therapy. Then my previous boss, Joe Mills, in Houston, he came up with the idea that not all diabetic feet are the same. And we have to put all the components we just talked about and come up with a grading system to know how bad the diabetic foot is. So he came up with the Wi-Fi classification, which is similar to the cancer TNM classification, where the wound ischemia and foot infection factors are all put in together to find out how bad the diabetic foot is. How do we evaluate that from the wound? We look if we have one, if it's neuropathic, ischemic, or venous, or is it mixed? The ischemia, we quantitate the ischemia. So we obtain non-invasive vascular flow studies like ABIs, PVRs, toe pressure, TCPO2, or pedal acceleration test. If venous suspected, we obtain venous reflex studies. Then for the infection, we look if it's localized or systemic, obtain cultures, search markers, and we evaluate the osteomyelitis with bilateral foot x-rays, MRI, and bone scan. Then we plug in these numbers, and you get a 3-digit number. You put it on the right-hand side table, and it'll tell you the patient if they benefit from revascularization and what's their risk of amputation. So what's the goal of limb salvage treatment? It's to relieve the patient's pain, heal the wounds, and preserve a functional limb. That limb should be functional. Don't just save the limb and spend months for a limb that the patient can't use. But just remember from the previous slides, 30% of those patients at risk of dying from cardiovascular events. So you have to minimize the risk of other major cardiovascular events while you're doing this. Because we have a saying in vascular surgery, life before limb. Okay. Okay, sorry. Did I do something wrong? Okay, sorry. What key points you have to keep in mind when you're treating diabetic foot? First, that many patients have a chronic peripheral arterial disease that will require multiple treatments, surveillance, and longitudinal care to achieve functional outcome. Also, as you've seen from the examples, many of those have advanced tissue loss, which needs support of the healing of the foot reconstruction. Large defect may take weeks, months to heal. The comorbid conditions slow down the healing, so you have to optimize them. Weight bearing stresses the wound, and concomitant infection will always make the wound worse. So all this is screaming for dedicated multidisciplinary care team to take care of this problem. So what's a multidisciplinary care team? It's a team professional representing different disciplines to assist in the evaluation and management of CLTI patients. And what they should be able to do, they should be able to perform medical evaluation and care, endovascular and open surgical revascularization, advanced foot surgery, wound healing therapies, physical therapy, nutrition, and adjunct therapies. I like to summarize the diabetic foot care of the 5 pillars of diabetic foot as infection control, revascularize, wound care, offload, and optimize glucose and nutrition. What about the 6th one? When you're done, these patients need to help them have a dispo. What's next? How are we going to prevent it? How are we going to prevent recurrence? Do they need rehab at home? Do they need a rehab facility? Do they have home care nurse? What do we need to do? Do they need a primary care physician? Many, they don't even have one. As for our experience at the Cleveland Clinic, Abu Dhabi, we formed a comprehensive limb salvage programs with these components, starting with US double board certified surgeons who are board certified in general and vascular surgery, supported by board certified foot reconstruction and wound care specialists, podiatrists, as well as dedicated, I lost the slides here, dedicated vascular medicine specialists. These are performed, guys. Okay. So the evaluation is done in a state-of-the-art hospital with advanced vascular lab studies. We have board-certified imaging physician and cardiovascular to read the CT scans, MRI, bone scans, PET scans. We have a dedicated antibiotic stewardship protocol, which based on the population of CCAD from cultures and sensitivities obtained throughout the years. All these, our surgeries performed in hybrid OR rooms where we can perform endovascular and open surgery at the same time. We have an in-house physical therapist, dedicated wound care certified nurses, and dedicated wound care clinic for the vascular surgery and limb salvage. And we have sister hospitals that we refer to for the long rehab and prosthetic care. The center is built on the guidelines of US and European societies of vascular surgery and diabetic foot. And the purpose of that is always to prevent amputation. But when you can't prevent amputation, you have to lower the level of amputation. Make it to the lowest level possible. Can I have the slides here, please? Very quickly, these are the things to show you the multidisciplinary team, the functions they do. I'm not gonna go through each one of them, but that shows you again, we go back to the 5 pillars and the disposition and what each team is contributing. It's not like one doing vascular, doing just revascularization. Everybody's contributing, and we have a very complex care. That's why you need the multidisciplinary team. And this is what our team does. So we started our program in June 2019 when I joined. And then 1 year later, we wanted to see, did we make any difference? Does it work? Or we should have just go to status quo. And in 1 year, we found out that we tripled the number of diabetic foot patients that we treated in just 1 year. Then what about the results? We reduced the amputation by 50%, and which is the blue bar compared to the orange bar, the number of patients we treated. Most of these amputations were even minor amputations. Then 1 year later, we wanted to look at our data and compare it to the global vascular guidelines on the management of chronic limb-threatening ischemia, CLTI. So we found that our amputation rate is 10.8%, which is less than half what's recommended by the global guidelines, with 0 mortality within 1 year in BKA and AKA procedures compared to the 10 and 20% accepted by the benchmark. So I want to illustrate to you very quickly a simple case of MDT and how it works and it helps. We had a 64-year-old female patient admitted for acute and chronic congestive heart failure, ischemic cardiomyopathy, low EF. She has a lot of comorbidities, coronary artery disease, CKD stage 3, and type 2 diabetes, hyperlipidemia, hypertension. Sick patient. While the cardiology team are rounding, they found that the patient has gangrene, and she was complaining of severe pain in the dorsum of the foot. As you see, it's edematous and erythematous. Inflammatory markers were elevated. We finished the entire workup. Cardiology team and our medicine team optimized the patient. And we obtained from vascular standpoint the PVRs. And as you see on the left-hand side, the patient has tibial disease with low TBIs and toe pressures. So the patient will most probably need revascularization. But we went to the Wi-Fi. We plugged in her numbers and showed that she has stage 4, clinical stage 4 diabetic foot, which means she will highly benefit from revascularization and high risk of amputation. So we took our patient to our hybrid room. We decided to do revascularization of the right lower extremity in an enterograde fashion using CO2 to protect her kidneys. We accessed the groin in enterograde fashion. Then we took our angiograms, the CO2. The large vessels are okay. In the middle is our anterior tibial artery, where it shows us severely diseased with no proximal, total occlusion, no proximal stump. And if you look, and at the end, it was, anyways, the DP comes back. So we decide to go in a retrograde fashion because that's the only vessel we have. The entire foot doesn't have any blood flow. We went back from the foot, as you see here, and we established what we call through and through. The wire goes from the foot, comes out from the groin. We have through and through. Now we can put our devices very quickly without needing to take more pictures and more contrast, more radiation, more time. We performed atherectomy of the anterior tibial artery, and this is before and this is after, where the patient has inline flow very quickly down to the foot. Then on the same setting, since we are in the hybrid room, we performed the 2 amputation with our podiatrist. Here she's performing the 2 amputation. We get the hemostasis, close the wound, and the patient has full treatment. And this is the sound of the blood flow in the foot at the end of the case. Next, please. So I want to take you through a couple of patient journeys, because I don't believe in before and after. As I said, you need functional foot. But what you have to look at more than that is what difference you make in these patients' life. Why are we here? Why are we spending all this time and resources if we're not making any difference in patients' life? So we have a 60-year-old, for example, patient with history of hypertension, AFib, and decompensated cirrhosis with ascites. Developed right foot gangrene, and he became really septic. He went to another hospital, and because he's cirrhotic, coagulopathic, and septic, he was offered guillotine amputation to be staged later, with telling the patient that even the BKA might not be feasible because of all your morbidities and tissue status. He was transferred to our hospital. where we optimized him clinically. We performed the debridement, we took out the infected toe. And after revascularization, extensive debridement, and optimizing clinically, we were able to heal his foot. So what's the significance of this? This patient was able to go back to his home country and get liver transplant. Then he texted us this picture, calling himself the new Mr. R. Another story of the patient journey is only a young 48-year-old diabetic male who's an anchor in a very well-known news channel in UAE. He developed right third and fourth toe gangrene, and he had received multiple treatments at local hospitals requiring long hospitalization. From the long hospitalization, he developed left heel pressure ulcer that extended all the way to his calcaneus and Achilles tendon. He was sent overseas, including Germany and Belgium, and over there, they were not making any progress. The patient became cachectic and was sent back to UAE, where he was depressed and cachectic. But at the same time, he had started having fever and became septic. So he was offered bilateral BKAs. We accepted the transfer to our hospital after performing multiple surgeries, including partial calcanectomy, debridement of Achilles tendon without dividing it, then lengthening it and covering it. We were able to heal, and this patient went back to his job very happily doing the thing he loves the most. Can you imagine for an 8-year-old back to work, what happened to his family, and that he can afford them and can spend quality time with them? What about the late presentations? You're going to have challenging cases, but at the same time, you should be ready to treat these patients and help them. This 7-year-old male, he came with he had for 1 year ignored his symptoms of wrist pain. That's critical limb-threatening ischemia, so he had gangrene of his toes. He was treating it with herbs, and nothing worked. However, his osteomyelitis progressed. He had pathological fracture of the ankle, and unfortunately, somebody put a nail in it, and now you have a prosthesis in an infected bone. What's going to happen? It's going to get worse. So he presented to our ED with a draining ankle and exposed prosthetic. Our first thought, we thought, okay, just to give him something functional. If we can revascularize this patient, maybe we can remove the hardware and just give him a leg that he can use even as a cane. But when we did the angiogram, the patient had no revascularization options. To add to the complexity, the patient has unstable angina. He was having this angina episode nonstop while he's in the hospital. Our cardiology colleagues took him to the cardiac cath, and they had no percutaneous option to revascularize him. So what do? They recommended cabbage. So the cardiac surgeon said, we're happy to do the cabbage, but we won't do it with infected foot. And at the same time, we wanted to control the infection since the patient is bacteremic and septic with BKA. Anesthesia said won't tolerate that, and we're not going to put him under anesthesia. So what we decided is, as a team approach, cardiac surgery and vascular surgery performed concurrent, off-pump cabbage, at the same time BKA, and the patient did very well. So what do we do with the patients when they amputate? That's done. We're not limb salvage program anymore. No, we refer them to our sister hospital where they undergo rehab, and this 7-year-old patient goes back on his feet. So very quickly, we ran out of time, but to conclusion, life before limb, but as you saw from the patient's journeys, saving limbs is saving lives. Revascularization is pivotal. No flow, no grow. Don't waste your time with oxygen, with antibiotics, with nutrition. Nothing gonna go to the wound unless you have good flow. You need aggressive infection control, reconstruct functional foot with podiatrists, orthopedic surgeons. A multidisciplinary team is a must. And it goes back to Dr. Armstrong and Dr. Joe Mills' model of toe, flow, and go. And just keep in mind, it takes a village to save a limb. This is my team in action on one patient during round. And thank you so much for having me in Riyadh. And if you ever come to Abu Dhabi, would love to see you there.
Thank you so much, Hussam, for your wonderful experience in UAE. So now we'll take you from Al-Emirat to Iraq with Dr. Ahmed Khayyat, consultant orthopedic surgeon, and also he's a consultant diabetic foot surgeon. We'd love to hear from Dr. Ahmed Khayyat about your experience in Iraq. Please welcome Dr. Ahmed.
Good morning, everyone. I would like to thank the organizer team for inviting me about this subject, especially Dr. Hani. Actually, I am orthopedic surgeon, and since 10 years ago, when I have a diabetic foot, simply below knee amputation. That's before 10 years ago. Until I saw one article talking about the prognosis of amputation for diabetic foot for 5 years in comparison with tumor. What do you think the incidence? I was shocked when I saw the incidence like or maybe more than the tumor. So I decided to make limb salvaging. And I learned some tricks about the limb salvaging for that. I will show you and I'll share my experience. By the way, my colleague from Kuwait, I think the habit of eating of our people the same. Yesterday, I saw one patient with diabetes sepsis all over, and I talk about the rice. I said, please stop. What he said? He said, I will die. That's the problem. Anyhow. Okay. I will talk about the rules of using the following biomaterials and procedures in diabetic foot management. The BMAC and exosome with stem cell. BMAC is bone marrow aspirating concentrate. And I will talk about the micro skin graft as well as the traditional skin graft. The placental amniotic membrane, autologous platelet-rich fibrin, the zipper device system for wound closure, magnesium and calcium sulfate, the ozone and the nanosilver, as well as the VAC system with silver dressing and offloading, and lastly, low-carb diet and good nourishment. So that's the first case. I have it, lady, 63 years old age, DM type 2, time of evolution 10 years, as well as the HbA1c 11. By the way, all our patients more than 10, the HbA1c. That's the parameters, you have it, and you see the ankle brachial index of 0.5, TCP or 235, neurological as well, upsetting the lab investigation, CRB titer 110, ESR 150, white BC 15, creatinine 0.9, and urea 50. That's the scheme showing the BMAC at the top under local anesthesia. We get it from the iliacris, either anterior or posterior, and then aspirated and concentrated and re-inject nearby the neurovascular bundle and around the wound. By the way, that's my own lab, private lab. Unfortunately, the Ministry of Health I think the same with Kuwait, neglected that subject for the diabetic foot, unfortunately. The second one was autologous bone marrow, and we make culturing and then go to flow cytometry to test the cells before injection. We have two approach. Either we direct inject the stem cell, or we make it as exosomal, which are degradation of the particles for the mesenchymal stem cell. That's lady. Unfortunately, when you have wrong surgeon and wrong hand, you will get bad result. This lady came from another colleague, just this articulation of the big toe and closure of the wound. All the arteries was blocked. We sent her for the vascular surgeon. But all the peroneal, anterior tibial, posterior tibial, all are blocked, totally blocked. He opened the anterior and posterior, and we do this result. Unfortunately, I am not satisfied for that result, bad result. The patient, I tried to satisfy her about the stem cell and exosomal with BMAC therapy, and that is the result. Okay, the next case for traditional skin graft, that is man, 70 years old age, the DM type 2, time of evolution 15 years, and HbA1c 10%. And you see the parameters all there. That was the case. So many colleagues, they said, please amputate. I said, no. I give him the chance. I start debridement. That's the one. And the next one, metatarsal amputation. And I did the skin graft for the case. That is the, and that's the end result for that patient. The next one is using of the placental amniotic membrane, post-cesarean section. Everything is sterilized, that's sample collection, and select and cut, and then wash. I use it for this lady, 65 years old age, DM type 2, time of evolution 17 years, and HbA1c is 13. You can see again the vascularity and the ankle brachial is 0.6, TCB 30. I isolate the amniotic membrane, that's the fresh placenta, and that's the wound for that lady, dehiscence. Suturing of the amniotic membrane, and that's the end result. Autologous platelet-rich fibrin, it is interesting one. We isolate from the blood, that's the policy we do it. I use it for a lady, 58 years old age, DM type 2, time evolution 14, and HbA1c is 14. And you can see the ankle brachial index as well as the TCB. That's the case, calcaneal osteomyelitis. That's the tragedy for that woman. That's at the time of presentation. We did the debridement, and that's the end result for amniotic membrane, for the fibrin. That is the end result. That is the device, what I think you know this machine, that is the zipper device. We make it on the edge, on both edges, and then we make approximation for the wound. Especially I use it for the dehiscence. That's one. And that's the colloid nanosilver. Actually, nanosilver is different from the silver article that we use traditionally because it is made from nanotechnology. We use it. By the way, all my cases I use this technique. That's offloading for our center. That's the offloading. Is the idea here that we have an ulcer and we have the cubic. We remove only the cubic around or around the ulcer edge and make the skin is clean to get offloading for that system. And that one. Again, the offloading. I love that one, and I hate this one. Why? Because so many cases I saw for that one go with charcoal because of imbalance and neuropathies. That again, type. That's interesting one. With calcium sulfate beads, we make the paste and impregnate with antibiotic, vancomycin and garamycin, and we make the granules, so many sizes. We have 2 sizes for that one, and that's the case we use, and that is the result. I use also the ozone therapy. I think most of you know the ozone therapy, topical O2 therapy. All my cases, I use it. That's the VAC system, again, I use it. And that's the end for the diet, foot ulcer with education of the carbohydrate, low carb. The above one, you can see the standard medical care with supplement and low carb nutrition supplement. It will decrease the interleukin 6 and faster wound healing. Okay. And that's my theater. If you like the fish, Masgoof fish, that's for us. That's our lovely river tigers. Thank you very much.
Thank you so much, Dr. Ahmed, for sharing your experience. Now we'll go for 5 minutes with the Professor Andrew Bolton. We'll take an advantage for his presence in our conference. It's very honor and great pleasure to have you, Professor Andrew, and we'll learn from the most expert people in diabetic foot. Please welcome Professor Andrew.
Thank you very much, Shukran. It's a pleasure to be here again in Saudi Arabia, and I was just a few months ago lecturing in this city of Riyadh on the diabetic foot at the second half of last year. I was here also a long time ago, and I see huge changes in this city. It's remarkable. And I knew many of the people here, and some of you in Saudi will remember Matt Malone, a podiatrist who worked, I think, at one of the military hospitals, and he actually trained in Manchester and went off to Australia, and I was able to visit with him, but that was 15 years ago. So just a few words about my experience over the last 40 years of research in the diabetic foot. I haven't got any slides because I didn't know I was going to have to do this. I'm standing in because the guy from Doha actually has not made it somehow. So first of all, the etiology. Now, in our first textbook, The Foot in Diabetes, published in 1987, I think, we said that the predominant ulcer in Europe was the neuropathic ulcer. But that's changed. In Western countries now, what we see most predominantly is the neuroischemic ulcer. Now here, and yesterday I was lecturing in Amman in Jordan, and there it's still, despite the very high smoking rates in these countries, the neuropathic ulcers still predominate, which is very interesting. And these are really easier to treat than neuroischemic. The causes of diabetic foot ulcer are neuropathy due to diabetes. It can be present at the diagnosis of type 2 diabetes because there's often a long delay from onset of hyperglycemia to the diagnosis being made. They may have no symptoms. They may present with a foot ulcer. So that's how long the hyperglycemia can be asymptomatic. So neuropathy is common. We heard from the first talk how common it is here in Saudi Arabia, and we published a paper at the end of the last century from the northwest of England showing that 50% of older type 2 diabetic patients had neuropathy. And of course, it's very common. It's loss of the gift of pain described in leprosy or Hansen's disease that is the main cause, loss of that gift. And also unsteadiness is very common because of large fiber neurological dysfunction. The patient loses joint position sensation, and it's often this that contributes to the development of the Charcot neuroarthropathy in these patients who are unsteady. They trip and continue to walk on a sprain which becomes a fracture because they've lost the gift of pain described by Dr. Paul Brand in leprosy. So all the way along, neuropathic ulcers are going to be here. But I fear that here, as in Europe, the neuroischemic ulcer will become more prominent. And it's the combination of ischemia and infection that really is the big enemy that leads it to amputation in many cases. In our recent review, we showed that 50% of people with diabetic foot ulcers will develop an infection. Of those, 20% may be admitted to hospital, and 20% will undergo some form of amputation. So we need to talk about prevention. Primary prevention is prevention of diabetes before it's diagnosed. And that's possible now we've seen from many studies, screening high-risk groups, and particularly in this region, family history is so common as we hear. Family history is people with first-degree relatives should be screened for diabetes. People who obviously have a significant obesity, a history of diabetes in the family, as I've said, gestational diabetes, and so on. So that can be prevented, moving into pre-diabetes into diabetes, and that's clearly shown. If you've got diabetes, let's prevent movement to getting complications. Screening. All the complications in their early stages can be silent. Retinopathy can present with blindness in one eye. We've shown in the UK that the National Diabetes Eye Screening Program, where everybody on the National Health Service gets a letter every year and they go for a retinal photograph, and if there's significant problems, immediately they're referred to an ophthalmologist. Diabetes, because of this program, is now no longer the number one cause of blindness in the United Kingdom. So that's silent complication. Nephropathy can be silent until they get nephrotic syndrome, severe edema, symptoms of uremia, itching, nausea, vomiting, etc. But it's so easy to screen for because the urine is the mirror of the kidney. And we can screen for neuropathy, simple tests. We don't need anything expensive. Paul Brand said, he was asked, and he was a professor and worked in Vellore in India, in leprosy, and later in diabetic foot problems. He was asked to speak at the American College of Physicians. And he was asked, what's the most important thing we can do to reduce amputation in people with diabetes? And being in America, they thought it would be an expensive scan or a very complicated test. He said, the most important thing you can do to stop or reduce diabetes amputations is every time you see someone with diabetes, remove the shoes and socks and examine the feet. So a careful clinical examination and a history, but you'll miss 50% of high-risk feet if you don't examine them, because only 50% of neuropathy is actually symptomatic. And then, of course, tertiary prevention is if someone's had a foot ulcer, let's prevent another one. And that's where smart technology is coming in, and we've published on that with smart insoles, warning the patient if the pressures are too high, and also a number of studies that temperature monitoring. The foot warms up before it breaks down. So that's screening, prevention, and someone was saying in one of the talks this morning that education doesn't seem to work. You need to involve the patient, empower them. And if they've got a system that warns them that they're at risk of a foot ulcer, and all they have to do is sit down and rest for a while, then that's easy to do if they understand. That's the most important thing. In terms of treatment, there's been a renaissance in recent years of good randomized controlled trials. Most of the new treatments before that had no real evidence base because the trials were badly designed. So we have a number of new evidence-based therapies. The American Diabetes Association every year in January publishes their standards of care, and their standards of care were published just last month, and you can see them free of charge by looking at Diabetes Care Supplement 1 2024. And for the diabetic foot, for level A evidence treatments that they now recommend, not for all ulcers, but for hard to heal, that don't respond to offloading, antibiotics, etc., for infection and so on. The level A evidence they give now is to, I've written it down here so if I can remember them all. The first is biologics, certain biologics we've heard some people mention today. The second is negative pressure wound therapy. Then there's the new leucopatch or 3C therapy, because that's the patch of centrifuge blood. It makes a patch of a disc of platelets, fibrin, and leukocytes, and you can apply that to the wound under a dressing. But it's not used much because it requires a lot of equipment at the bedside. So ErgoStart, or the sucrose octasulfate dressing, has good evidence now in a randomized controlled trial. It's not recommended by the ADA because it's not available in America. So I think that's still a very useful treatment. And now there is good evidence for topical wound oxygen therapy. Topical, not hyperbaric. Hyperbaric is not given any recommendation now because the recent trials have all been negative. But topical oxygen is up and growing and coming, and it can be done at home, and they give that level A evidence. There's also last year's guidelines. We heard in one of the talks about the international working group, and I was involved in setting up the international group in the diabetic foot in the late 1980s. And they do these guidelines every 4 years, very carefully done, and they make a number of recommendations too, which you can also see free of charge on their website. And there are Wound Healing Society, there are many guidelines. So read them and remember they are advice, not dictating what should be done, and that should be taken into account when you treat the patient in front of you. So I'll end with something, a little quotation, if I get it right, from Edward Wilson. And he said, "If I listen, I forget." So this is probably a complete waste of time. If I see, I understand, so using slides is better. But if I'm involved, then I will follow that instruction. So the modern technology is helping us for patient feedback by temperature monitoring, by pressure monitoring, and involving the patient so they understand is empowering them, and then the education will work if you involve them in their own care in addition. And they understand what neuropathy is. We showed in a study that most people with neuropathy, if you ask them, they think it's a vascular problem. Because everybody knows about vascular disease, but they don't understand neuropathy. How can my feet be at risk? Because they feel great, they're warm, and I don't feel any pain. So they need to understand, it's like an electric wire feeding a light. If the wire breaks and doesn't conduct the electricity, the light goes out. And you can use simple terms like that to help patients understand what loss of pain means to them. So with these few thoughts, I wish you a very successful conference. It's nice to see a full hall and how people are now really interested in helping people reduce the very high mortality and morbidity from having recurrent diabetic foot ulcers. Shukran.
Thank you, Professor Andrew. So we'll conclude this session with Dr. Talal Anizi. He will share his experience from Qatar. He's the head of pediatric service, senior consultant and foot and ankle surgeon, Hamad Medical Corporation. He will be online with us today. We would love to have him physically, but due to his emergency circumstances, so he will be with us online. Please welcome Dr. Talal.
Assalamu alaikum, thank you. I don't know if you guys hear me. Okay, I think you do hear me. I hope you do. I will go ahead and start right away for the time's sake. We looked at the diabetic foot in the state of Qatar as one of the major issues and health aspects that we really need to manage because it's causing a lot of heartache for both the patients and the healthcare organization. So we compare our circumstances with the both the United States and us to see what's the difference of the healthcare in regarding to the diabetic foot. So we see that the number of the prevalence of diabetic patients in Qatar is almost 30% more, and it is about 3 times fold higher than in the US. And although the number of physician to patient ratio is almost the same as the US, the beds is only about, or the inpatient beds, only 44% of that of the US. Also, one of the major reasons, as you know, the hospitalization for the patients with diabetes is due to diabetic foot ulcers. So if we try to prevent them from going into the hospitals, then we have successfully managed this case. Next. Some of the complications that we notice, please can you keep going with the slide? I'm not managing it, I don't know how. So the number of population, the Qatari population is only about 10%, 10 to 15%, with 60% of the population don't speak the local language. Also, the other obstacles is the beliefs of the traditional beliefs and these wounds, and they're not able to present to us in a timely manner. Next. So in 1999, the diabetic foot clinic started, and wound center only was a small room for a screening under the endocrine department. Now it went into a major center with its own operating room, physical therapy, gait labs, orthotic section, and with multiple satellite clinics. So, and we're able to manage more. Next. The numbers, I joined 2006, it went up from almost 6,000 to more than 28,000 patient visits seen in 1 year. Next. What we did is hired a multilingual staff with different languages from anywhere from, again, English, French, Spanish, to the Arabic, the Urdu, Filipino, Tagalog languages, multiple languages, staff workers to try to relay the proper message and the education for both the patients and his family or their families. Also through public awareness by inviting students and giving lectures both in classes and in universities, as well as having some TV programs and educate the public being aware of this problem, the diabetic foot injuries. Also in newspaper articles and interviews. Please, next. And next again. What we thought is that maybe if we embark on trying to do some research, try to find the new technology may help us and try to manage this problem better. With the help of other national research funds and HMC funds, we're able to do multiple research, which I will share with you next. Our first study is to see how to better manage the diabetic foot ulcer by managing the dose of activities. And we know that with even little unprotected injuries that may lead to a devastating consequences in people with diabetes. Next. So we know that the offloading is widely considered as the single most important intervention in managing the diabetic foot ulcer. Offloading is reducing the high foot pressure, which allow the healing of the ulcer, and at the same time allowing the patient to ambulate. You notice through this, by managing with the offloading, that the pressure in the midfoot has improved. Next, please. Although some challenges with the offloading is that they're kind of heavy, so there is a poor adherence to the offloading, as well as there is once you place the patient in offloading, the muscles of the leg become weaker, and that may lead to a recurrent of ulceration or new ulcers at a different site. Also, there is no guideline in dosaging of the activities. There is, we say, too little activities is bad for the health, and too much activities is bad for the wound healing. Next. Next, and next, next. Okay, so back up, please. One more slide. Okay, so we see over here there are different studies and articles saying and supporting that excessive loading of the foot leading to a poor wound healing, and again, too much activities, no activities is bad for the blood supplies, and it may harm the wound healing in the long run. So we need to find the sweet spot in between those two ideas, and they're correct. And that was our research question. Next. Okay, so we use this innovative technology, which is a sensor that is placed inside a t-shirt that the patient wears for 48 hours. Next, please. And with this, we're able to evaluate and see what this patient is doing for the next 48 hours as they're wearing this t-shirt. Is the patient laying down, sitting down, standing, walking, running, jumping, and within real life time and measurement. Next. Also, we asked the patient, again, we did this research taking about 84 patients with foot ulcers and divide them into two arms. This is a double-blind study. Both the patients nor the physician know what modality of care and what type of ulcer is receiving this type of treatment. Both of them are cam walkers, one with the ability that the patient is to remove the walker, and the other one is we locked it so the patient is unable to remove it throughout the day and night. But the patients with the removable walker, we told them try not to remove it as you are walking or standing. Next. And after 7 weeks, next please. Next. Okay. Back up. Okay, so a 7 weeks period, we noticed that by just adhering to the education and the treatment protocol, by locking this cam walker, we're able to improve the healing by almost 88%, and this is almost a 100% improvement by just adhering to our treatment protocol. Next. And keep going, please. Keep going. Okay, so this is what the sensor gave us, this information. And this information, one more, please. Okay, so you see almost 80% of the time the patients are actually sitting down or laying down, and only 5% that the patient is actually walking. But what we found that there is about 15% of their time they're actually standing. And we found that within standing is really where the danger is happening for these patients who are diabetic with foot ulcers. Next. And we see over here that we're able to dose the activity by, you see over here the removable one is the blue dot and the red squares is the removable cam walkers. With walking up to 5,000 steps is pretty safe and will not injure the wound. Actually, it helps heal the wound faster if you walk up to 5,000 steps with the use of an uploading device. Now, the danger, on the other hand, next, is that the patient, when they're standing, if they're using this device or the uploading device, then they're okay. But if they're not using the uploading device, then this is where the danger comes by removing it and standing on their feet unprotected. Next. Also on this busy slide, we noticed that the patient really presented to us at an early stage where the wound is small and manageable. We're able to heal them faster from this busy schedule. Next. What we found also is that by placing the patient in a removable cam walker for 4 weeks, we actually made the muscles of the leg very weak and frail. And that frailty is really a danger for these patients. And so again, it's almost 50% frailty after 4 weeks, where we and increased that by almost 450% frailty score. That lead to a 4-foot pressure, and this 4-foot pressure lead to further recurrence of the ulcer. Please, next. Again, keep going. This chart over here, one more. Okay. That at the beginning of where the ulcer may develop at an early stage of this patient's life, that it's a small ulcer and very easy manageable. We place them in an uploading device. This uploading device lead into again weakness in the muscle. This weakness in the muscle, about 40% of these patients will develop another ulcer. With time, the ulcer takes longer to heal and longer period of being placed in this uploading device, and this uploading device caused them to become more frail and more weaker, and that muscle unable to dorsiflex the foot and causing a forefoot pressure very high, especially at the toes and the metatarsal head, that lead to the ulcer to reoccur sooner and sooner, and then that may end up into amputation. And that what gave us an idea for our next research. Next, please. Again, you can see over here that the slow muscle recovery lead to a forefoot, slow muscle recovery in the calf lead to forefoot pressure and subsequent ulceration. Next. So this conclusion that what we said that by 80 we improved the speed of wound healing with the use of proper uploading and proper education and the patient to be adhered to it. There is the harmful activity and the dosage of numbers of steps. What we did in this research by allowing them to walk up to 5,000 steps in a protective uploading device is very good for them, but making sure that they are using this protective device and it's properly uploading them at the right spot. Also, we noticed, we said that after 4 weeks of being in an uploading device, we need to place these patients in an exercise of the foot and ankle to try to regain the strength of the calf and leg muscle. Next. Next, please. Okay. So again, this exergaming, okay, so there is a high risk of fall in a patient with diabetes due to the loss of protective sensation or neuropathy, where in the studies anywhere from 5 to 12 times higher than the general older population. After a prolonged period of time, as I mentioned, due to weakness in these muscles, they end up having a recurrence of the ulcers and chance of, okay, next please. Again, if I'm not able to control it, but physical activities is very important. We can tell them to use these aerobic exercises and resistance exercises, but then improving. If I can control the slide, I can move faster. Next, please. So regular exercises with foot and ankle are good, but they're not actually engaging into the brain. Next, please, next. Next. So we need to educate the brain as we do in that and in our research. Next. The Tai Chi, the yoga, the Pilates exercises, they do engage the brain, but it's very hard for our population in this region. Next. Again, next. So in the study over here, we did one more, please. I don't know if this is present or not. The exergaming, it's a game video as the patient is sitting down. They are placed in an exercise fashion, and through the game, it's like a Wii game that they move their foot and ankle range of motion, and they're able to gain their balance and their strength of their lower limbs. Next. The third one, I'm not sure, you mentioned to me is the time is up. I'm not sure if I can continue or not. Hello? I don't get feedback. Anyway,
thank you so much, Dr. Talal. I think you're running out of your time. So we'll conclude this session. We had a great experience and with great lessons from different countries. And I think the conclusion of this session, I think Gulf countries and Egypt and Iraq, they have some obstacle. We're sharing the same obstacles. And we're doing a great job. I hope we continue doing the same work what we are doing. I think involving new technologies improve our patient care. We're always fighting for amputation. We keep amputation as the last resort. Prevention is the most important. At the end, we would like to thank our distinguished speakers and Professor Andrew Bolton. We have a small thing to give you before you leave for the break. Please, Dr. Lamia and Mr. Abdullah Al-Arabi, come to the stage. Any questions about the sessions until the... As a small appreciation to our distinguished speakers, please let's have Dr. Khalid Idris here in the stage, and thank you for sharing your experience. You can go from there. For our second speaker, Dr. Nasser Al-Hamidi from Kuwait, thank you so much. Third speaker from Egypt, Professor Wala Khalifa. Dr. Muhammad Hatim from Bahrain. من الإمارات دكتور حسام يونس. Actually, I think they have an excellent multidisciplinary team. I like the way how they do endovascular and vascular intervention at the same time they do the surgery, which is that's the excellent example of multidisciplinary team approach. Thank you, Dr. Hussam. من قطر الدكتور طلال العنيزي، بس ما احنا عارفين كيف نوصل لك هو دكتور طلال، بس نرسل لك هو ان شاء الله باذن الله. We would like to thank Professor Andrew Bolton for his presence with us. Just your presence, Professor Andrew, is valuable for us. Thank you. Our colleague Dr. Ahmed Khayyat من العراق. تفضل دكتور أحمد. Which surprised me, Dr. Ahmed, they're using advanced technology in Iraq. I thought they have limited resources, which very impressive actually to see your experience in using stem cell therapy in diabetic foot. يعطيكم العافية. ناخذ بريك وحيكون الافتتاح إن شاء الله بإذن الله بعد تقريبا 10 دقائق. شكرا على وجودكم معنا، يعطيكم العافية. لولا الله ثم دعمكم ما
هتقرا منه بس ولا انت هل بيبقى فيه كومنتس انت حطيتها تحت السلايد؟
لا اي كومنت
انا اقصد بيكون في شاشه سوداء غير السلايد موجوده.
لا لا
هو السلايد فقط.
بس تتحرك السلايد.
السلايد انت هتحركها من الريموت ده.
لا هيتحرك كده يدور
انا بتكلم ان اللاب ده هيكون عرض فقط لانه مش متوصل على السيستم. هو شغال هنا بزوم ميتنج.
طيب
بيعرض فقط.
طيب.
فالتقليب هيكون بالريموت يمين او يسار. دي بيقدم ده بيرجع.
لا بحرك الصور.
الصور نفسها هتتحرك؟ لا يبقى اوتوماتيك.
اوتوماتيك؟
اوتوماتيك.
يعني اضغط اي شيء اضغط اي شيء هنا.
لا هنا انت مش هتضغط اي حاجه، هنا بس فقط هيعرض.
بس طب انا نحرك الصوره كيف؟
الصوره اوتوماتيك. انت اول ما تفتح السلايد هتشتغل اوتوماتيك. اوتوماتيك مش هتعمل اي حاجه. ممكن برضه تجربها مفيش اي مشاكل.
WhatsApp list. حبيبي الله يسلمك. وانا كذلك والله كذلك الحمد والله بارك امورك نورتنا الله يسلمك.
وصول المسؤولين لانطلاق المؤتمر بإذن الله. طبعا هم الآن أخذين بريك بانتظار وصول المسؤولين لانطلاق المؤتمر بشكل رسمي. نسأل الله يجملنا يا رب. يعطيك العافية حبيبي. استفسار. السلام الملكي. بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف الأنبياء والمرسلين، نبينا وحبيبنا وقدوتنا محمد عليه وعلى آله أفضل صلاة وأتم تسليم. ثم أما بعد، راعي المؤتمر سعادة وكيل الوزارة المساعد لخدمات المستشفيات الدكتور فيصل بن سالم الدهمشي، الحضور الكرام، مشاهدينا الأعزاء، السلام عليكم ورحمة الله وبركاته، وأسعد الله صباحكم وجميع أوقاتكم بكل خير وتوفيق، ومرحبا بكم في المؤتمر الثاني للقدم السكرية المقام في الفترة من التاريخ 27 فبراير إلى 28 فبراير لعام 2024 للميلاد، والذي يهدف هذا المؤتمر إلى استعراض التحديات وآخر التطورات في مجال القدم السكرية لإيجاد الحلول والوصول إلى أفضل النتائج. وخير ما نبدأ به آيات من الذكر الحكيم.
قال إبراهيم رب اجعل هذا البلد آمنا واجنبني وبني أن نعبد الأصنام رب إنهن أضللن كثيرا من الناس فمن تبعني فإنه مني ومن عصاني فإنك غفور رحيم ربنا إني أسكنت من ذريتي بواد غير ذي زرع عند ربنا ليقيموا الصلاة فاجعل أفئدة من الناس تهوي إليهم وارزقهم من الثمرات لعلهم يشكرون.
صدق الله العظيم. حضورنا الكريم، نترككم مع كلمة ترحيبية مع الدكتور عبد الله بن محمد السهيمي، مدير عام شؤون المراكز المتخصصة في وزارة الصحة، فليتفضل مشكورا.
بسم الله والحمد لله والصلاة والسلام على رسول الله محمد بن عبد الله وعلى آله وصحبه ومن والاه وعنا معهم برحمتك يا أرحم الراحمين. وبعد، سعادة وكيل الوزارة المساعد لخدمات المستشفيات الدكتور فيصل بن سالم الدهمشي، ضيوفنا الكرام، حياكم الله جميعا في هذا الصباح الجميل، ونرحب بضيوفنا من خارج المملكة من زملائنا في دول الخليج العربي والدول العربية، ونقول لهم يا ضيفنا لو جئتنا لوجدتنا نحن الضيوف وأنت رب المنزل. حياكم الله جميعا. أزمة القدم السكري طبعا هي أزمة فعلا، أزمة في الوطن العربي مثلها مثل بقية مناطق دول العالم. لا يخفى عليكم جميعا أهمية موضوع القدم السكري. في المملكة العربية السعودية موضوع السكر موضوع من المواضيع المهمة والتي تلقى رعاية وعناية كبيرة في الوزارة. شرفنا الدكتور فيصل صراحة في المراكز المتخصصة أن نكون الحاضنة لبرنامج القدم السكري. القدم السكري بدأ من يمكن 2013 كبذرة بثلاثة أشخاص، دكتور تركي، دكتور عبد الله عربي، ودكتور فيصل. وقتها كان هو مدير عام المراكز المتخصصة وكلفني مكانه. والآن نعتبر أن المؤتمر اليوم هو أول حصاد لموضوع أهمية القدم السكري. متوقع منا إن شاء الله مع هذه القامات العلمية أن يكون لدينا policy و procedure، وأن يكون لدينا privilege للمراكز القدم السكري، وأن يكون لدينا قاعدة بيانات يمكن أن تكون قاعدة بيانات دولية يمكن الانطلاق منها. طبعا موضوع الجفرنس هو الموضوع حوكمة أي عمل في القطاع الصحي من الأشياء المهم الآن التركيز عليها. دائما ينقل لنا سعادة الدكتور فيصل وقيادات الوزارة موضوع أن نكون نافيجيتور، لا ننظر فقط إلى الأوبريشن. الزملاء ما شاء الله تبارك الله يعني قائمين بأدوار عظيمة، وقدم السكري موجود جنرال سيرجري فيه، وموجود دايبيتولوجيست، وموجود الفاسكولار والبلاستيك، وموجود الجنرال براكتيشنر أيضا يتدخلون، وأيضا بعض الممارسين الصحيين ومتخصصين، ولكن لا يوجد حوكمة بشكل واضح. متوقع من هذا المؤتمر إن شاء الله في توصيات المؤتمر أن يكون لدينا حوكمة العمل وليس فقط فهم أهمية العمل، لأن الجميع متخصص لكن الجميع يحتاج إلى governance. هذا المتوقع إن شاء الله خلال يومي عمل وورش عمل علمية مكثفة. وأعيد والترحيب بكم ونقول حياكم الله، وإن شاء الله نستمتع جميعا خلال اليومين القادمة. شكرا.
شكرا للدكتور عبد الله السهيمي على هذه الكلمة الترحيبية، ونجدد الترحيب بكم وبالسادة المشاهدين الكرام وبضيوفنا القادمين من خارج المملكة العربية السعودية، وضيوفنا وضيوف المؤتمر من داخل المملكة في محطة من محطات وزارة الصحة، هذه الوزارة التي تمشي بخطى ثابتة ومدروسة للوصول إلى أفضل النتائج في كافة المستويات لمواكبة رؤية المملكة العربية السعودية 2030. نترككم الآن مع كلمة رئيس اللجنة العلمية للمؤتمر الثاني للقدم السكرية الدكتور هاني بادحدح، وتشاهدون أيضا عرض مرئي أثناء هذه الكلمة.
الواحد ما عارف إيش يقول، يعني لما يشوف المؤتمر الأول القدم السكرية والأعداد القليلة والشركات المشاركة، وكانت بذرة خير. واليوم أشوف الحضور هذا والناس واقفة ما شاء الله، والانترست يزيد في الدايابيتك فوت. أنا فخور بنفسي وفخور بزملائي وبفخور فيكم الصراحة، إنه صرنا نعرف إنه في مشكلة في القدم السكرية. كان الناس يعتقدوا إنه القدم السكرية أي أحد يعالجها، أي أحد خلاص زي ما قالوا الدكاترة جرح في النهاية حينتهي بموضوع بتر، نقطع الرجل وخلاص وانتهينا المشكلة. الناس ما يعرفوا قد إيش تكلفة البتر، قد إيش الشخص يكون معاق ويكلف الدولة، قد إيش قيمة الطرف الصناعي. مؤتمر القصيم للقدم السكرية كان هو بداية أحد نجاح مبادرات القدم السكرية. كانت 5 شركات راعية، اليوم عندنا ما شاء الله تبارك الله أكثر من 18 شركة راعية. كنا بدون شركة منظمة، كانت جهود شخصية، والحمد لله كان نجاح باهر للمؤتمر. الآن واليوم إن شاء الله بإذن الله بدأنا القصة الصباح، وأتمنى أنكم تستمتعوا في القصة وتهتموا بالحضور، لأنه تم اختيار الجدول العلمي بدقة، ليس يشترط فقط للأطباء وإنما يشمل جميع التخصصات، وهذا هو الهدف، المالتي ديسيبلينري تيم ابروتش. I'm not targeting only physician, I'm targeting diabetologists, endocrinologists, physical therapists, vascular surgeon, intervention radiologists, wound care specialists, surgeons, foot and ankle surgeon, pediatric surgeon, orthopedic surgeon, podiatrists. So I hope you enjoy the next few days with us, and we have 2 intensive day of lectures, and also we have 4 workshops. Today we have 2 workshops, will start at 2, and tomorrow we have another workshop, will start at 2. And I hope you guys, you enjoy the rest of the day. Thank you.
شكرا لرئيس اللجنة العلمية للمؤتمر الثاني للقدم السكرية الدكتور هاني بادحدح على هذه الكلمة. ونترككم الآن مع توقيع اتفاقية بين الإدارة العامة للمراكز المتخصصة في وزارة الصحة وجمعية إسماف. بعد هذه الاتفاقية تستمعون الآن لكلمة للدكتور محمد زمزمي، فليتفضل مشكورا.
بسم الله والحمد لله والصلاة والسلام على رسول الله وعلى آله وصحبه ومن والاه. أشكركم جميعا على حضوركم لهذا المؤتمر. والحقيقة أنه هذا المؤتمر كان بذرة سابقة بدأت يعني فكرتنا جميعا في الدايبيتك فوت أنه نغطي 2 مليون حاج ومعتمر، والعدد هذا صراحة كان بدأ من الميدان بفضل الله عز وجل، ثم بدعم القيادات الوزارة تم يعني توقيع هذه الاتفاقية هذا اليوم. نتوقع بإذن الله تعالى أن يكون هناك بنوك للمتطوعين الصحيين المؤهلين والمدربين تحت إشراف أكاديمية إسماف المعتمدة من هيئة التخصصات الصحية، وأيضا التابعة لدرب المفازة الوقفية المعتمدة من هيئة الأوقاف، وأن يكون هناك تفعيل للقطاع الوقفي في خدمة ضيوف الرحمن وفي دعم كل من يحتاج لهذه الخدمة، لأن المتطوعين هم يكونون متواجدين طيلة موسم رمضان وأيضا موسم الحج، ويكونون أشبه بالنفيجيتر كما أسلفوا الزملاء، ينظرون في خدمة هذا الضيف ويعتنون به صحيا في مجالات شتى، من ضمنها ضربات الشمس والانهاك الحراري، صحة الحشود. لكن هذا المؤتمر وهذه المبادرة ستكون بإذن الله تعالى هدفها نقل التجربة ونقل المعرفة للجيل القادم، جيل المتطوعين الصحيين، من ميدان أوسع وأرحب وهو ميدان المشاعر وعرفات ومنى والحرم. ويكون بإذن الله تعالى هؤلاء المتطوعين يعودون لمناطقهم في كل مناطق ومحافظات المملكة العربية السعودية وجامعات وكليات الكليات الصحية، ليكونون بإذن الله تعالى بنوك من المتطوعين الصحيين القادرين بإذن الله تعالى على خدمة هذه المبادرة، مبادرة القدم السكرية وهذا البرنامج، سواء كانوا مقدمين ومساعدين في الخدمة أو كانوا حتى باحثين وجامعين للبيانات. ونتطلع حقيقة لدعمكم جميعا من قيادات الوزارة، جزاكم الله خير، الدكتور فيصل، الدكتور عبد الله والدكتور محمد، دكتور هاني، حقيقة دائما ما يعني يقفون دائما ويمكنون المتطوعين ويؤمنون فعلا بدورهم، وأيضا يكون لهم تواجد ملهم حقيقة لنا في أيام الحج بحضورهم، مما يعني يسهم حقيقة في أنه نقل الخدمة لتكون في ميدان بإذن الله تعالى أوسع وأرحب، وتكون متصلة ومحوكمة مع مركز أو مع المراكز الصحية المتخصصة إلى التجمعات الصحية، وأيضا إلى يعني أهداف أعمق وأعلى من خدمة يعني شريحة غالية علينا وهي شريحة ضيوف الرحمن. أشكركم، أشكر دعمكم. نتطلع بإذن الله تعالى لأن نترجم هذه الاتفاقية إلى أعمال ومبادرات لتعرض بإذن الله تعالى في المؤتمر الثالث كإنجازات ومخرجات شهدتم توقيعها، وتشهدون بإذن الله تعالى إنجازاتها ومخرجاتها. السلام عليكم ورحمة الله وبركاته.
شكرا للدكتور محمد زمزمي على هذه الكلمة، ونجدد الترحيب بكم في المؤتمر الثاني للقدم السكرية، والآن اعتماد مركز الشيخ فهد العويضة للقدم السكرية للمرة الثانية من قبل وزارة الصحة.
الأستاذ أحمد السبهان والدكتور عبد الرحمن الصقعبي والدكتور فهد البديوي، تفضل.
من منطلق قول الرسول اللهم صل وسلم عليه: من لا يشكر الناس لا يشكر الله. يتفضل الدكتور فيصل الدهمشي وكيل الوزارة المساعد لخدمات المستشفيات، وأيضا الدكتور عبد الله السهيمي مدير عام شؤون المراكز المتخصصة بوزارة الصحة، والدكتور هاني بادحدح رئيس اللجنة العلمية للمؤتمر الثاني للقدم السكرية لتكريم الشركاء. أولا تكريم اللجنة المنظمة الأستاذة نسيبة الحربي. الأستاذ محمد الباحوث. الأستاذ سعد الفايز. وأيضا تكريم لإدارة الهوية. ودرع التميز السنوي في القدم السكرية يقدمها الدكتور هاني بادحدح.
This year we started to make some kind of competition. I start this annual award of excellence in diabetic foot. There is a lot of competitions, but we have to select one person. So this guy, he was inspiring me, and he started from diabetologist and then become like a medical director of Diabetic Food Center. And then in few months, not few years, became the manager, general manager of the King Fahd Specialist Hospital. And he's the one supporting and pushing for diabetic food service in Qasim area. Please welcome Dr. Turkel Mekbil, and he will be the first one to receive the annual award of excellence in diabetic foot. And I hope next year we have more competitions, and we have a lot of expertise in this field, but we have to select one, and this selection came to Dr. Turkel Mekbil.
والآن تكريم للشركات الداعمة للمؤتمر. شركة مونليكي. وأيضا تكريم لشركة أميكو الشركة الداعمة لهذا المؤتمر. وأيضا تكريم للشركة المنظمة شركة الخيول الثلاثة لتنظيم المعارض والمؤتمرات. والآن تكريم أو تسليم درع تذكاري لراعي الحفل الدكتور فيصل بن سالم الدهمشي وكيل الوزارة المساعد لخدمات المستشفيات. فعاليات المؤتمر لا زالت مستمرة إلى يوم غد 28 فبراير لعام 2024. والآن ندعوكم لتدشين المعرض المصاحب وتقبلوا تحيات محدثكم ناصر الحربي، والسلام عليكم ورحمة الله وبركاته.
عشان نبقى احنا جايين. حلوة درش.
Bismillah ar-Rahman ar-Rahim. Now we are going to start the first session for this conference. The first session will cover endovascular and vascular surgery. And this session, the modulator will be Dr. Hussam Yunus and Dr. Muhammad Hatim. Please welcome them.
Hello, everyone. Welcome back. We'll kick in the vascular session with Dr. Nasib Al-Wahabi. He's a vascular surgery consultant at King Fahd Specialist Hospital, Al Qussein, and he will be talking about indication of diabetic foot referral to vascular.
Assalamu alaikum. I'm Dr. Nasir Al-Wahabi from King Fahd Specialist Hospital, Al Qussein, Buraida. This is the main hospital in
Can
Al
we
Qussein.
fix Dr. Nasir's microphone, please?
Yes. Clear voice? Yes. So I will talk about the indications of referral of diabetic foot ulcer to the vascular surgery. Diabetic foot management is always about three main components. It's about the comprehensive assessment, multidisciplinary teams, and early intervention and follow-up. Comprehensive assessment is about the clinical presentation, vascular status, wound, and over the medical condition. Multidisciplinary teams, including vascular surgeon, IR, podiatrist, and endocrinologist. The early intervention and follow-up, usually optimizing the outcome and prevent the complications. So why we refer it to the vascular surgery? Because of up to 34% of diabetic patients will develop diabetic foot ulcer in their lifetime. And up to 40% of patients with peripheral arterial disease and tissue loss will have major amputation. After the healing ulcer, 40% will have recurrence at 1 year. So the first indication is peripheral arterial disease, which diminished blood flow to the lower limbs. About the history of the peripheral arterial disease, usually between the asymptomatic and claudication. Claudications, 5 years outcome, cardiovascular mortality is about 30%. This is the main issue of peripheral arterial disease. Limb morbidity, it's about the mainly about the critical limb ischemia. When there is tissue loss or wrist pain, it's about 1 to 2% from the peripheral arterial disease. But when happen, amputations reach up to 40%. Risk factor, smoking is 2.5 to 3 times, diabetes 3 to 4 times, hypertension, and history of hypercholesterolemia, and age more than 70 years. Other risk factors known: atherosclerosis, other sites like coronary, carotid, and renal artery disease. The second indication is the critical limb ischemia, which is a severe form of peripheral arterial disease. It's all about the wrist pain at the foot, gangrene or non-heal ulcer, or disabling claudication. The summary of 6-month outcome from the 19 studies about critical limb ischemia: alive with amputation 35, dead 20, alive without amputation 45. So the physical examination always, it's about signs of ischemia, from the inspection, the thin skin, hair loss, brittle nails, color changes, pallor, ulcers, muscle wasting. The patient about temperature, cold, pulses, capillary fill, sensation, and movement. Berger test also is one of the signs of critical limb ischemia and peripheral arterial disease. So this foot ischemia showing left side normal, left is pallor and cold. This is ischemic ulcer at the big toe. And the main thing about the assessment is vascular laboratory. Non-invasive vascular assessment should be performed in all patients with the signs of peripheral arterial disease. It's about the ABI toe pressure, duplex arterial scan of lower limb. And the study show ABI more than 0.8 and tissue and toe pressure more than 60. It's adequate for the ulcer healing. ABI less than 0.3 and 30 millimercury toe pressure, healing is unlikely. So it's essential for treatment of peripheral arterial disease. This is one of our cases in King Fahd with critical limb ischemia, non-healing ulcer at the heel and the amputated toes. And it was included the stent done outside the hospital, included the SFA stenting after angioplasty. It shows retain the blood flow to the lower limb and healing ulcer. This is within 4 months. This is another one, also is 70 years old with a critical limb ischemia, tissue loss, amputated, and show there is no flow in the foot, and show the SFA was included with the popliteal tibial, stenting of the crossing of the SFA with the stenting, and then retained flow to the tibials and down to the foot. So this is after almost 6 months of from the procedure. It's almost closed the wound. So other indication is other severe peripheral neuropathy. And the most important thing about the indication to referral to vascular surgery is risk stratification, which one is the vascular assessment, and the risk stratification identify individual at the high risk for a future complication, and is amenable for the vascular intervention or not. So learning point is risk factor about peripheral vascular disease, recognize signs and symptoms of the chronic ischemia of lower limbs, differential diagnosis of leg pain, examining the chronic ischemic limb, understand the importance of management of peripheral vascular disease, knowing when to refer to the vascular surgery. So it's all about the teamwork and multidisciplinary team, and thank you.
Thank you, Dr. Sakhar. We'll move on to our next speaker. Sorry, I apologize. The next speaker is Dr. Sakhar. Dr. Sakhar is a vascular and endovascular surgeon at the Department of Saudi German Hospital Group and the coordinator of the endovascular unit there. He had extensive training in Germany and very active with multiple societies like the SVS and the Critical Limb Ischemia Global Society. He also the secretary of the Vascular Art, the Global Conference for Advanced Revascularization Technologies in Jeddah. Welcome, Dr. Sakhar.
Thank you, Dr. Hussam. Thank you very much for this kind invitation from the scientific committee, Dr. Hani, of course. I'm going today to speak about the invasive versus non-invasive study about diabetic foot ulcers. Okay, I have no conflict of interest regarding this talk. So, as we can see here, in everyday practice, we are facing such cases of Rutherford class 4 and 5 and 6 also, critical limb ischemia with diabetic foot gangrene. And it's estimated in high-income countries that up to 50% of patients with diabetes and diabetic foot ulcer suffer from underlying peripheral arterial disease. So to know the role of vascular insufficiency, here is the diagram showing that diminished blood flow leading to a slow healing process that is increasing the risk of infection, exacerbating the limb ulcer, and leading to focal gangrene. So as we mentioned and our colleagues mentioned before, the prevention is the golden rule. And the early detection that leads to prevention that will lead to prevention of amputation. So regarding the vascular study, it was mentioned in other previous colleagues' presentations. I will go through the deep details of vascular assessment. And vascular assessment here includes non-invasive and invasive procedures. Non-invasive, like the clinical assessment plus some supportive tools, the radiological assessment, and the invasive, either direct angiography, CO2 guided or contrast guided, and intravascular ultrasound, of course. This is the basic rule we have to start with. I'll be in the next minutes shuffling through from the basic to most advanced tools for vascular assessment, so please don't be bored from the statistics. And the most basic tool, as we all know, is the hand palpation. This is a major role for inguinal vessel to primary detect tool for vascular insufficiency. Then shuffling to ankle brachial index. Once upon a time, it was the gold standard for critical limb ischemia diagnosis as a most used assessment tool, but recent studies showed that in diabetic patient, it is potentially unreliable for ankle brachial index to detect CLTI, as the arterial stiffness and arterial calcification is increased, and that leading to misleading results. Of course, the score of ankle brachial index is well known and how to proceed with measurement. And in American Heart Association also, it mentioned that in asymptomatic patient, we can rely on ankle brachial index. And in some symptomatic patient, plus pulse volume recording, duplex ultrasonography, and Doppler-derived ankle brachial index can be reliable. Of course, the severity score, we all know that from 0.9 till 0.4 from the severe, mild to severe, and also it's from heavily calcified vessels more than 1.3. This is the recent studies about the ankle brachial index, and it concludes that the diagnostic performance of arterial derived Doppler ankle brachial index is showing the sensitivity of 72% and the specificity of 95%. So the value of less than 0.9 has been identified as a threshold for detecting significant stenosis and arterial stenosis more than 50% in diabetic patient with type 2 diabetes. And in systemic review and the meta-analysis that recently showed that poor sensitivity of ankle brachial index and lack of evidence for its performance when used in combination with other tests, and we cannot at the present recommend it as to rule out only, depend on ABI to rule out the peripheral arterial disease in patients with diabetes. Shuffling again to brachial index with a ratio of the systolic pressure to the brachial systolic pressure. And the advantage over the ABI is it's less affected by medial artery calcification in diabetic patients. The toe pressure index is considered more reliable than ankle brachial index, and the threshold of this TBI is less than 0.7. It's more sensitive and cost-effective than ABI, and in healing prognosis, it had been determined that less than 30 millimeter mercury suggests a low likelihood of wound healing, and less than 45 is patient unlikely to heal the wound. Again, shuffling to the pulse volume recording. Measurement of volume changes in the extremity with a cardiac cycle is a segmental pressure, taking the volume changes as shown here. And this, as Dr. Hussam also mentioned, and the ratio and lesion impact ratios between different segments will be maintained in absence of hemodynamic significant lesions. So if I have a significant lesion, if I don't have a significant lesion, the volume will be maintained. Even the waveform morphology is not normal. Transcutaneous oxygen pressure is a non-invasive, non-radiological measurement for local oxygen released from the capillary. This is 2023 most updated study about the transcutaneous oxygen pressure, and it shows that the normal value is 60 millimeter mercury, but it has some disadvantage also, that it can be underestimated or overestimated according a lot of factors, such as skin quality, sclerosis, edema, inflammation, room temperature, bone prominence, superficial tendons, superficial veins, patient in stress or sitting, standing. It have a lot of variant factors. And included that the transcutaneous oxygen pressure value can predict wound healing process of ischemic lower extremity injury. This is also according to the meta-analysis, recent meta-analysis. It showed that the BI and pulse oximetry and ankle arterial waveform can be assessed and have demonstrated some promising result in the diagnosis of CLTI. Shuffling to the duplex ultrasound, evaluating the vascular anatomy and hemodynamic function. The diagnostic accuracy for this one, sensitivity is 89% and specificity is 100% with accuracy of 95%. So the color duplex enhances the accuracy by evaluating direction and velocity of flow, and it considered the gold standard non-invasive test. The performance here provides better accuracy, but still it dependent on the transducer positioning and the highly trained operator. Challenges and consideration in this one, the sensitivity and specificity of duplex ultrasound for peripheral artery disease may vary based on segment-to-segment comparison. It have a lot of significance in smokers with diabetes and also non-smokers with diabetic patient, and it showed recently that some score from guided from the duplex ultrasound can be more beneficial, as the duplex ultrasound can diagnose the intimal thickening, stenosis, thrombosis, collateral flow, and distal flow, and by evaluating a lot of data, giving each a certain score that provide information can be utilized for future management. This is also the systemic review and meta-analysis. It shows that recommendation of all patients with active diabetic foot ulceration should go for full lower limb duplex ultrasound for assessment of peripheral arterial disease. The CTA, the computed tomography and geography, it's depending on the morphological evaluation of patient with unknown or suspected peripheral arterial disease. It has some advantage, of course. It's cost effective, widely available, and offer excellent level of anatomical detail. In the recent meta-analysis, it showed accuracy of 95% sensitive, and it detected lesion with more than 50% stenosis. But on contrary, it has some disadvantage. Doesn't provide the physiological information we had from the duplex ultrasound. The CTA cannot distinguish from between hemodynamic significant lesion and renal insufficiency, of course, with contrast media, potential leading to acute kidney injury. Some calcium showing arterial artifact, especially in BTK. This is a recently multi-detector computed CTA, a recent form of CTA, and it showed in some studies that sensitivity is 84%, specificity at 87%, and accuracy is 86%. The magnetic resonance, in comparison to the CTA, MRA is not susceptible to artifact, either in heavy calcified vessels, superior imaging of tibial vessels compared to CTA, but also it have some disadvantage. It's time required, the cost effective, and limited extravascular anatomical information. It's also having some risk at the implanted pacemakers and defibrillators and nephrogenic systemic fibrosis. So we had to think deeply about the MRA. We had a new vision of arterial spin labeling. This is a magnetic resonance imaging that enables measurement of perfusion non-invasively at the tissue level. And the advantage here is providing valuable insights into muscle perfusion dynamic, actual life dynamics. Then to improve this, we had now the blood oxygenation level dependent MRI, the bold MRI. Bold MRI capitalized on the paramagnetic properties of hemoglobin. So it's considered the hemoglobin as an endogenous contrast agent. The advantage here is precise semi-quantitative evaluation of relative changes, and this advantage is time required and cost effective also, and it's susceptible to motions and variable spatial resolutions. Recently, we had hyperspectral imaging. This is non-contact technology measuring the microcirculation by quantifying tissue oxygen saturation. This is a recent study for this one. It's showing the oxygen saturation level. and it has some effective in prognosis of diabetic foot ulcer. This is a real-time imaging technique, captures differences in light absorption, and it measures tissue characteristic based on the spectral characteristic. It is comparable to transcutaneous oxygen pressure value and diagnostic potentials. The VOTI system is a vascular optical tomography system. This is using the red and near-infrared light. It illuminates the foot to create cross-sectional images of hemoglobin concentration. Again, like BOLT technique, we are depending on the hemoglobin concentration. It's a non-invasive and doesn't require contrast agent, and it has no adverse health effects. The advantage here, it can penetrate deeper than the laser Doppler. It's independent from arterial calcification and provides direct measurement of perfusion. The comparison with traditional diagnostic modalities, there is no contrast here, like in CT and MRI. The limitation of pulse, it negates the limitation of pulse volume recording and the challenging of duplex in visualizing lesion below the knee. The importance of direct foot perfusion, it has, we have to understand the effect of lesion or the stenosis. Indirect methods may miss crucial perfusion performance, leading to ischemic ulcers. And in the future, we have basis for planning large multi-center study trial to support the VOTI system and future studies to control the risk factors and understood their effect on VOTI results. Spatial frequency domain imaging. This is a non-contact optical imaging also that depend on hemoglobin in the dermal microcirculation and macro circulation. And this study about the SDFC concludes that it's feasible, rapid, and easy to evaluate the lower extremity perfusion in patient with or without diabetes.
Dr. Ahmed, if you can summarize the talk for us, please.
So I will jump through this one to the
conclusion, please.
Conclusion. In conclusion, in International Working Diabetic Foot Group, it showed that in a person with diabetes and a foot ulcer, what is the validity of clinical examination in order to identify or exclude the peripheral arterial disease? The sensitivity of clinical examination is too low. In person with diabetes and foot ulcer, which bedside diagnostic procedure alone or in combination has the best performance? To evaluate the pedal Doppler, it wasn't in combination with ankle systolic pressure. No single modality has been shown to be optimal, and there is no definite threshold value above the peripheral arterial disease. Thank you.
Thank you, Doctor. Thank you for your presentation. Now for third presenter, Dr. Mohammed Salah. He's the Chief Vascular Surgery Department and Diabetic Foot Clinic in Saudi Germany Hospital, a founder and chairman of Vascular Artery Conference and Vascular Artery Clinic, exam to Royal College of Surgery in Ireland, and professor of surgery at BMIC University of Jeddah. Thank you.
Thank you very much. I would like to thank our friends, Dr. Hani Badahdah and Dr. Khalid Idris, for inviting me here. And I would like to start with the management algorithm for peripheral arterial disease. Actually, we deal with diabetic foot that the foot of every diabetic should be dealt with as diabetic foot. And just we have more than 250 million worldwide diabetics, and these are the distribution. This is 2007 and supposed to be 2025. With some countries in our area, in the Gulf and Middle East, we have about 80% increase. Of course, foot problems, the largest number of hospital bed stay, and at least 1 to 4% develop ulcer annually, and about 75% of extremity amputations are diabetics, and 85% of them are preceded by foot ulcers. 2/3 of the elderly patients undergoing amputation never return back to the independent life. Of course, Dr. Hani Badahdah was talking about the cost for amputation. Of course, the cost of saving limb is much less than the cost of amputation, and these are scary statistics from the US. But the most important, that we have 74% of patients had amputation was actually preventable. In Saudi Arabia, we are one of the highest percentage and one of the top countries in prevalence of diabetes. It was 2.8 million in 2011, and now it's 4.3 million in 2000. In 10 years, we had more than 2 million more. We should never forget when we have a patient, we should never forget the best medical treatment. For the glucose management, lipid, blood pressure, antiplatelet, and anticoagulants, these are very important to take care of the general condition of the patient. And these are the ankle brachial index we just heard from Dr. Sakr. And these are the recommendations also of the duplex and CT, also heard before. The recommendations, of course, if you have an ideal situation, we should examine all the patients annually to exclude peripheral arterial disease. Ankle brachial index or toe brachial index is very important. We can use the Wi-Fi classification. Always consider vascular imaging if the ulcer does not heal in 4 to 6 weeks, regardless the results. And always consider revascularization in a patient with diabetic foot ulcer, again, if they did not heal in 4 to 6 weeks, despite optimal management. Do not assume diabetic microangiopathy. Microangiopathy can cause poor healing of an ulcer, but does not cause the ulcer. So when the patient has ulcer, you should assume vascular problem, macroangiopathy. Of course, when we are doing revascularization, we should aim to restore direct blood flow. At least one of the foot vessels should be continuously revascularized. There is no evidence about the endovascular or the open or the hybrid, which is the best. So the decision should be tailored according to the patient. Each patient is different. Of course, they should be managed on an urgent basis and should be managed in a multidisciplinary approach. Angiosome concept, of course, we all know this. We have 6 angiosomes in the foot, and these are the angiosomes. 6 angiosomal comes from the 3 vessels. So whether to do single or complete revascularization, actually there is no difference between single and complete in the terms of major amputation. But there is a significant difference in healing ulcers. These are the meta-analysis showed that they considered direct and indirect, and they showed that direct reperfusion resulted in significantly improved wound and limb salvage. We have some cases where is the cases? I have a problem here. Can I use mine? I'm sorry for that. I just wanted to say one comment. I heard something which I liked very much in the morning from our friend from Kuwait, that the diabetic foot is an orphan disease. Nobody wants to adopt. Actually, you can see that all the diabetic foot patients are, shifted from one clinic to another. Nobody wants to adopt. So I liked very much this one. Sorry again, I have to these are the cases. This is one of the complete popliteal artery occlusion. And this is the only one in the foot posterior tibial artery. We did this revascularization of the posterior tibial, and then the anterior tibial, and then the peroneal. So our main aim, usually we try to go for complete revascularization. This is another case, has no anterior tibial, and only having very good posterior tibial, but nothing in the anterior tibial, just recanalization of the anterior tibial, and then we have the foot. This is another patient who had amputation of the big toe. This patient, by the way, has a very good posterior tibial pulse, and that's why the surgeon was encouraged and did amputation of the big toe, but actually he has no anterior tibial pulse, and as we saw, we had gangrenous stump. We tried hardly to go through the anterior tibial to reach the dorsalis pedis. We could not reach the dorsalis pedis at all from the anterior tibial, but strangely enough, we could reach the dorsalis pedis from the peroneal artery, and as you see, the balloon is coming from the medial side to the dorsalis pedis, and this is the final result. And this is, we do amputation of the, you can see that the blood is coming. We do always debridement immediately after angioplasty. Another case, again, popliteal artery, and this is the final result. The breakthrough, which I consider really the breakthrough in ulcers, are the skin bioprinting. This is the 3D bioprinting. It has very good and very clear indications. The procedure is very simple, that we scan the wound and then we take some of the fat of the patient, we micronize the adipose tissue, and then we use this fat as a printing material, and we print the skin and we apply to the ulcer. These studies were done, and they gave us 87% healing in 12 weeks. These are some of the publications which was done. Again, some cases. This is a very huge ulcer that is refusing to heal, and this is the machine which we used, and this is the during the procedure, we take the fat from the abdomen and we micronize this fat, and then the machine, after we take scanning of the wound, they make a scaffold for the ulcer, and then we start printing the skin. This is the scaffold. The ulcer is very big, so the machine made it in 2 halves, and this is during the procedure. We put, this is the printed skin, and this is after we put it on the ulcer, and this is the other half, and this is during in the next few weeks, and this is the end of it, and this is the, as you see, in 12 weeks we have no graft. It's normal skin in 12 weeks. Another case, as this is the printed skin on the ulcer, and this is in 9 weeks we had this. So this is the progress of the ulcer. In 9 weeks we reached this. Thank you very much.
Okay, thank you, Dr. Mohammed, for your presentation. Now for the fourth presenter, Dr. Abdulaziz Al-Gassar. He's Associate Professor of Department of Radiology and Nottingham College of Medicine and Medical Science Qasim University, Qasim, Saudi Arabia. Vascular intervention radiologist in Qasim University Medical Hospital. Dr. Abdulaziz, you're more than welcome.
Good afternoon, everyone. My name is Abdulaziz Gharras, one of the intervention radiologists from Qasim. Today we'll talk about endovascular therapy in ischemic foot, and is endovascular helpful? So I'm going to present our center experience in doing that. I can't. Okay. I have nothing to disclose. As you may know, diabetes has been growing over time. We are expecting to reach up to 45% in 2030 if we do not work on reducing the disease and protecting our community. It's also quite common, especially in old population with type 2 diabetes. I have a few cases to share with you. The first case is a 66-year-old male with multiple comorbidities, poorly controlled diabetes, hypertension, heavy smoker. Patient had dry gangrene of the first, second, and third toes, which turned to be moist. On exam, no popliteal, anterior tibial, or posterior tibial pulses. Multidisciplinary team was to control the infection, after which revascularization will be planned. So that's our diagnostic angiogram, which showed a severe focal occlusion and the mid-SFA with a single runoff and from the posterior tibial, otherwise no significant flow distally to the foot. Patient had high creatinine at that time, so we did a single angioplasty of the SFA and let the patient go and reassess clinically if symptoms improve or not, which unfortunately did not improve. So 2 weeks later, so that's the wound. It can show there's a poor granulation. The wound is pale, and there is no sign of healing expected. So 2 weeks later, from the first angio, we did a second look angiogram where we can see a single posterior tibial artery, and there is no runoff in the anterior tibial or peroneal artery. Successful recanalization was done with wire and balloon. We had a much better flow at the end of the procedure. This is only 2 weeks after the procedure. You can see the tremendous change in the flow and in the healing of the wound with a good diabetic foot surgeon hand. And you can see 2 months later, complete wound healing, some keratosis at the wound, but the wound is completely healed. So the message we learned from this patient is, one, early workup your patient. Revascularization of ischemic wound will enhance your healing and prevent extensive surgical options. Always advocate for revascularization at the time of dry wound. Do not wait till the infection happens and then your choice of treatment will be very limited. My second case is a 20-year-old female with multiple comorbidities. She had a dry gangrene of the second and third toes. She has been on that for a few months. She was denied, in fact, endovascular treatment or even open bypass. She was given a choice between either conservative or balloon amputation if turned to be wet. She presented to our hospital with a wet gangrene after she went a toe amputation. Exam-wise, there was no pedal or popliteal pulse. And a CT angio was done, which showed long segment SFA disease with moderate short segment SFA occlusion. You can see the wound 2 days after the amputation. There is some sort of blood on it. So decision was made, let's wait and see how the wound goes. 3 weeks later, just that sloughing. There is no sign of good wound healing. So we decide as a multidisciplinary team to revascularize this patient, give her a good option of treatment. You can see from the CT, patient is morbid obese, okay? So, and she had multiple disease throughout the SFA and the common femoral artery. We did a right groin axis up and over angiogram that confirmed the finding. In fact, the SFA disease is even worse than what we expect. Successfully, we were able to recanalize it. We improved the flow with some linear non-flow limiting dissections. 2 weeks later, you can see how much the changes in the wound. Tremendous improvement, excellent wound care help in taking care of the patient. 30 days and less than 2 months, complete healing of the wound. This is the difference between conservative and revascularization of the patient, and that's what can end up to your patient. Delayed wound healing is an excellent indication for revascularization. I usually choose between 4 to 6 weeks. If I do not see any good sign of healing after that, the patient has to do additional workup. Always offer your patient all the possible treatment options and include them in your decision making. Include them in your plan and your process. Our third case is a 52-year-old male with multiple comorbidities. He had a dry gangrene of the first big toe. Doppler showed popliteal and posterior tibial pulses, but no anterior tibial. And our decision was to do revascularization, as the patient was in dry wound, and then a plan for amputation. So that's the wound. We can see dry gangrene of the big toe on the left side. This is diagnostic angiogram, which showed focal severe stenosis in the mid-SFA on the right side of the screen. 2 segments, as well as severe tightness of the distal anterior tibial, however, still patent. But what we can see is the big toe, we barely see any flow going to the wound. So there is no wound blush in this patient. Successful recanalization, angioplasty and stent placement in the SFA. You can see at the end on the right side of the screen, you can see there is a good wound blush to the wound. Patient underwent amputation. 3 weeks later, complete healing. This is a magic. Early revascularization is a key to accelerate your wound healing. This is how it will help your patient. Case number 4, a 72-year-old male with multiple comorbidities. He has a very poorly controlled diabetes. He has a non-healing ulcer in the right big toe, plantar surface infection. He had a Doppler ultrasound done outside, which showed normal triphasic arterial flow. The surgeon was not happy about the report. He did not feel the pulses, so he was not very comfortable. You can see the wound. It's very ischemic wound of the big toe. In fact, there is some question if there is some moist gangrene on it. This is a report which shows it's a triphasic normal flow, just some atherosclerotic disease. We did diagnostic angiogram. There is very poor flow, especially focal moderate segment complete occlusion in the mid anterior tibial. There is multifocal disease of the anterior tibial with multiple extensive collaterals. There is a severe asymmetry in the flow of the anterior circulation compared to the posterior circulation. There is some flow to the foot, but it's not enough to heal the wound. We had successful recanalization of the anterior tibial, balloon angioplasty and recanalization. Posterior tibial completely open. We can see the flow. This is a selective angiogram from the anterior tibial. You can see the difference in the flow of the anterior tibial pre and post. This is a patient journey from day 0 after amputation till day 21. Tremendous healing, excellent healing. So always look for a second opinion and ask for a second opinion if you are in doubt of your patient. And again, revascularization is a key to accelerate wound healing in the dry time, especially. The guidelines in diagnosis and management of peripheral arterial disease in diabetic foot ulcer indicate that any normal exam does not exclude peripheral arterial disease. Always assess arterial Doppler waveforms, ABI or tissue PI, skin perfusion, tissue oxygenation. There is no single modality can exclude peripheral arterial disease. If you are concerned, just work your patient up. In case of delayed wound healing, more than 6 weeks, consider follow-up imaging, consider revascularization, consider other possibility before you call patient this is a microangiopathic disease. During revascularization, always aim for at least single artery, preferred inline flow to the wound, and you saw, and prefer to have a wound blush at the expected wound. After revascularization, always include the multidisciplinary team in your work. Always reassess your patient, see your patient, check him up, because that's what will help you and guide you in your management. The revascularization in 8 weeks in patient with diabetic foot ulcer predicted to be a good sign for a probability a good wound healing in patient without major amputation. So take-home message, do a good clinical exam for your patient. Delayed wound healing is more than 6 weeks, require additional workup. Earlier intervention will prevent major amputation, and a teamwork is a key to success in fighting diabetic foot. Thank you so much.
Thank you, Dr. Abdulaziz, for sharing great endovascular cases. Now we'll move from minimal invasive to maximum open with Dr. Haytham, who's a vascular surgeon and the surgery residency program director at King Faisal Specialist Hospital. He will be talking today about open bypass indications and how to do it.
Assalamu alaikum wa rahmatullahi wa barakatuh. Sabah al-khair. Good morning, everyone. Thank you for the invitation from the committee, the chairman of the committee, Dr. Hani. I think they love me too much to assign this topic to me, which is أنا أسميه السهل الممتنع. The indication for bypasses in diabetic foot and the ischemia. أنا أسميه السهل الممتنع في التوبيك هذا لأنه more and more of vascular modern surgeon nowadays are becoming more skillful in the endovascular approach, and it's more attractive, the endovascular approach. So I think we need to concentrate on the basic and the bypasses for the next generation. And this was recognized by the SVS. I have no disclosure. The SVS recognized that, and based on their guidelines in the diabetic foot and the critical limb ischemia, they actually, and combined with the international, translating these guidelines more with the European Vascular Society and the other global societies. And they came up with a huge document, it's about 200 pages, where the section 6 on this describes the evidence-based revascularization in those patients. And the main goal for evidence-based revascularization is to have an effective flow into the wound, and it should be a systemic approach to improve the decision-making, clinical outcomes, and the cost-effectiveness in delivering high quality of patient's care. And the main 3 steps integrated a paradigm for decision-making in every practice. So it's not a straightforward, easy question, this guy or this patient should get a bypass or not. You should take the patient or the case as a whole, where you decide about the patient's risk estimate. As Professor Salah mentioned in his, there is no clear answer on deciding on between endo and open bypasses. So you should take it as a whole picture of the patient's risk, including age, comorbidities, limb staging, and we're going to come to that, including the Wi-Fi staging, and the anatomical pattern of the disease. You can use the GLASS classification or any anatomical disease pattern. Taking this integrated paradigm, you will eventually have an idea what's best for the patient. And the patient risk estimate is the first step, is to involve the limb salvage, perioperative risk, and life expectancy. CLTI and diabetic foot associated with advanced age, comorbidities, and frailty on most of those patients. But your goal is to how to relieve the pain from the wound, how to heal the wound, and how to preserve a functional limb rather than have just a stick attached to the body. The estimation of the operative risk and life expectancy plays a critical role in evidence-based revascularization. And you can use different tools, and it's been described in the past in the literature and developed, and you can apply them. For example, this is the list of several objective tools that you can use to stratify your patient. And we can see that the majority, almost all of them, and the end point, they included all-cause mortality, major amputation, amputation-free survival, and perioperative events. Again, the clinical factors of the patient or risk patient, mainly age, comorbidities. Diabetes actually has a huge role in this, and smoking, BMI. And what's interesting in those patients with the diabetic foot, also they have a high incidence of end-stage renal disease, which again impact the clinical factors on those objective tools. The limb staging, as many of you know, that the SVS threatening classification Wi-Fi system is recommended to use. Unfortunately, I've noticed that in Saudi here, they don't apply this in many centers, which I think we should start applying it in clinics, diabetic clinic and peripheral vascular disease clinic, in order to have an objective pre and post and decision making of what's the next step. I'm not going to go into details about this Wi-Fi classification, but basically describe a wound severity, ischemia, and the foot infection. And they grades in the wound, you have 0 to 3 grades. Then the infection 0 to 3 as well, based on the ABI and the ankle brachial plexus, ankle brachial pressure, and the tissue, oxygen tissue concentration in case of diabetes in those patients. Then the infection is depend on the presence of the infection, how bad is the infection, and you integrated all that in a calculator, and it gives you the grades on the Y and the severity or stage on the x-axis. And we can see here that stage 1 to 4, they actually not benefit from any revascularization because it's very severe. However, when you increase the grade, not the stage, the grade, from 2 to 3 or 2 to 4, they're the best patients who benefit from this revascularization. So that gives you an idea, again, the patient's risk, limb staging, then the anatomical pattern of the disease. And the best thing, and I encourage everyone to use this, is the glass, although there is some take on those glass classification and how to class them. But basically what you need is to restore an inline flow. This is your goal when you decide which path you go with the revascularization. You want to have an inline flow into the ankle, and that's your primary goal. And the target arterial path, or TAP, is a continuous route of the inline flow to the groin, from the groin to the ankle. And the limb-based patency, LBP, is to maintain that patency of that TAP even with a single runoff or single inline flow. And calcification is considered only if severe, increase within segment graded by 1. So when you take patient with CLTI or diabetic foot, or CLTI with diabetes scanned for revascularization, you want to see how high the quality of angiographic imaging, including into the ankle and foot. Then you decide about your TAP or target arterial path. Then you classified based on FIMPOP segment or infrapop segment, and inframedular as well. Then overall the glass criteria will decide if this patient, in addition to the Wi-Fi as we talked about, to give the best next step on your plan. Which brings us to the availability and quality of autogenous vein also needs to be assisted in your preoperative decision making. Both saphenous vein, greater saphenous and shorter saphenous on both sides, and should be defined before revascularization decision, especially in average risk patients. So the existing evidence argues strongly for selective revascularization algorithm based on special clinical anatomical scenarios, as we describe in our paradigm, including patient risk, limb severity, and the complexity of the anatomical disease. And the Basel trial, Basel 1, remains the only multi-center random control trial to directly compare the endovascular first or bypass first. And we're not going to go through the Basel trial because it can open a lot of debate and question, but basically the take-home message of this is although the intention to treat analysis showed no significance between the two-arm endo and open in this Basel trial for the overall survival and the amputation-free survival. However, 70% of patients who lived longer than the study itself, 2 years, it shows that those who treated initially with bypass had a better outcome, especially in the amputation-free survival. Again, the evidence-based revascularization strategy is there are several multi-center data, including the Basel itself and other regional registries, suggest that the outcome of the bypass in patient who undergone failed endovascular significantly inferior to whoever had the bypass primarily before any intervention. And the inferior outcome associated with the secondary bypass, similar whether the initial failure are percutaneous or prior bypass. So the importance consideration to avoid risking potential loss of the target and performing endovascular intervention should be considered. And this is the key of having a multidisciplinary decision-making and perioperative workup on those patients. Although the bypasses has a significant morbidity mortality, factor increase the wound infection from the surgery itself, graft failure, post-operative complication, long hospital stay, we should all consider these in our calculation preoperatively as well. But basically, after you stratify the patient, after you study the limb anatomy and the severity of the disease, also you want to check the inflow, outflow, and the inframalleolar, as well as which is this patient going to benefit from a primary infrainguinal bypass or not. And an acceptable target of the bypass should prevent or provide, adequate runoff to the lower limb to resolve those clinical situation, i.e. the wound. And in the setting of stage Wi-Fi 3 and 4, it's recommended that the selective target artery provide continuous inline flow. That's the key. You have an inline flow to the foot or to your ankle. And the good quality saphenous vein should be saved, and it's the optimal autogenous conduit for infrainguinal bypass surgery. Alternative like a small vein or an arm vein, small saphenous or arm vein, is still inferior to the saphenous vein and a single long saphenous vein. And of course, prosthetic graft or the prosthetic with a distal bypass patch is still inferior to all of these. So when you have a clinical limb ischemia, diabetic foot, you did your Wi-Fi, and it's stage 3 or above stage 2, is this candidate for a limb salvage or not? If no, you consider palliative or amputation. If yes, then you again estimate the procedure risk and the survival of those patients over 2 years. Consider revascularization. If that's considered, you want to study your glass or any anatomical calcification. Then based on that, you will decide if the revascularization is feasible or not. If it's a high patient, personally, I think endovascular is the first to go. If it's a low risk or standard patient, then again, you need to step back and rethink about what's the best for the patient before you proceed with anything and commit anything. And those patients with the young patient who has a good saphenous vein, who has a moderate or low risk factor, long segment occlusion, extensive tissue loss, I think bypass should be the main role of those patients before an attempt of anything. So it's not an easy decision, and it's not an easy answer. You need to consider patient's risk, extent of the anatomical staging system, inflow, your outflow, the surgeon experience, and the future plan will this patient, is your goal is to heal the wound? Is he going to need the saphenous vein and cabbage? Is he going to need the saphenous vein in the other limb? Is the patient going to have failure of or recall of his occluded graft? All this should be considered and taking care of that patient. And thank you.
Thank you, Dr. Haytham. Very important message. The patient selection is a key and proper workup. Don't never rush into any therapy without the proper workup.
Okay, thank you, Dr. Haytham, for your presentation. For our last presenter, Dr. Nasser Hamidi, he's a general surgeon and diabetic foot surgeon with a fellowship in Spain. He's the head of diabetic foot unit in Farmania Hospital in Kuwait, and he will talk about when a major amputation is needed.
When I was approached first initially to give this talk, I thought I only had one talk and that's it. But then suddenly Dr. Hani said, no, Nasser, you have another one. And your title would be about when major amputation is needed. خنقتني العبرة لما نزل إياها, because I truly didn't know what to do. Here I am, a diabetic foot surgeon. My main goal and my main aim is to prevent amputation. Now here I am talking to you guys, trying to explain why we should do amputation, totally contradicting. So thank you, Dr. Hani, for this. You gave me really difficult nights, I swear to God, trying to find a reason. So what I've decided to do is to give you my both aspects out of all of my experience of when I do amputations. I do amputations, unfortunately. Now there is a Nasser with an emotion, and there is one without emotion. So the one with the emotions, this is what I do. When is amputation really needed? This is me. This is what I do. If I follow the 3Ds, and this is my usual thing. If it's dead, if the limb is dead, if the limb is deadly, in other words, it's causing harm to the patient, and if it is deadly useless, not useless, but deadly useless. So this is what I usually deal with if I have to decide to do an abalone amputation or a major limb amputation. So now, with what Dr. Hani had informed me to regarding this, so I need to get rid of my emotions and discuss with you the proper reasons of when to do an amputations. First, we have to define what a limb salvage surgery is. So it's a preservation of the limb, of the ankle joint, and avoidance of any major amputation. Partial foot amputations, we could get these definitions through online and we all know them. But the major ones are below and above knee amputations. And you need to differentiate between minor and major amputations. So achieving limb salvage and preservation of the lower extremity function in patients with diabetic foot disorders is pretty much a highly coordinated effort that involves addressing abnormalities involving the musculoskeletal, cardiovascular, and neuropsychiatric systems. Successful limb salvage, in other words, with preservation of the entire foot or a minor amputation, is pretty much unlikely. It's unlikely to result in an improved function in patients with residual deformities, instability, or any chronic infections or contractions. So these select patients with these complications may actually better achieve a major amputation. So what are the epidemiology? Now globally there appears to be a trend towards reducing the rate of lower extremity amputations, which is a good sign, and particularly with regard to major amputations. Ramsson and colleagues have reported that the rate of lower extremity amputations has been decreasing, and that has attributed to the better management of diabetes and its complications. But despite this, nearly 73,000, this is all from the States, 73,000 diabetic-related amputations were performed in 2010. We are in a decline. We are getting better, but we still haven't reached the end point. And this is what I meant on having on a positive note, that the amputations in Medicare have also dropped substantially from 2000 to 2010, and more of these amputations were performed distally. During this 10-year span, major amputations declined from 58,000 to 37,000. In other words, there is a 37% reduction rate in major amputations, whereas minor amputations now increased. So according to one major diabetic foot physician, whom I know, he claimed that minor amputation saves the foot, major doesn't. So if you just grasp this idea that minor amputation to the transmetatarsal is considered as minor, you're actually saving the foot, while major, as everybody knows, you're not. So what are the goals? What do we want to achieve? We need to achieve an ulcer-free, plant-grade foot that is functional. This is a job of Dr. Hani Badahdah now. In other words, we have to have weight bearing on soft tissue that is not accustomed to weight bearing pressure, would define a non-plantar grade foot. This, for example, is a non-plantar grade foot. If you decide on not doing an amputation to this patient, then you need to have proper management. In other words, either proper offloading or reconstructive surgeries in which the foot would have proper plantigrade. Or else, this patient, as we all know, will ulcerate. If he ulcerates, he has a high rate of, you had increased his mortality rate, and even that, you had gone to the initial circle of which he would end up in major amputation. So this is a patient with a severe varus deformity. As you can see now, the lateral column on his right foot is pretty much deformed. And if he's going to continue on like this patient will end up in an above-knee amputation or a below-knee amputation. So he would require reconstructive surgeries. Hence, we have this multidisciplinary team. If he has a wound or a vascular compromise, we deal with it with the vascular surgeons. After that, diabetic foot physician or any of the wound healing specialists would deal with the wound. And then after that comes like Dr. Hani Badahdah, and they're pretty much as a reconstructive ankle foot surgeon is pretty much essential. So what's shocking is that Sohn and colleagues have found that Charcot's neuropathy, patients who have a Charcot's neuropathy, and they presented with a diabetic foot ulcer, had a 12-time higher likelihood of undergoing amputation compared with patients with Charcot's neuropathy and no ulcer. It's really very, to me, when I saw this, it's just something, something which I cannot even grasp. So reconstructive limb salvage surgery. And the main goal of it is, correct me if I'm wrong, Dr. Hani, is surgery must to attempt to restore normal biomechanics with the attention to improve sagittal and the transverse planes. In select patients, the key word select, major amputations may be necessary. This is me without any emotions. Would I do it? No. But do I have to say it? Yes. Ethically, I have to say it? Yes. Would I do it again? No, I would not do amputation, even with this. But this is me speaking. But because what Hani Badahdah did to me, so I had to say this now. Mashkoor yani. This is the mortality and morbidity of diabetic foot diseases and amputations. We all heard them, we all know them, we all grasp the idea about of it. Is that a patient with a diabetic foot disease has a worse prognosis than many forms of malignancies. Could you imagine a patient who has an amputation after a diabetic foot ulcer has a mortality rate of 53%. A patient with a Charcot disease has an amputation, has a 5-year survival rate of 55%, compared with a patient with breast cancer who has a 5-year survival rate of 89%. Now, something which comes into mind, just speaking of this, we have diabetic foot, we have breast cancer screening, and we have colon cancer screening. 64% 5-year mortality, survival rate, and 89% respectively also with breast cancer. But we have nothing diabetic foot screening, even though it's worse. Something really ridiculous. So with these findings, that what they had found, the authors, is that limb preservation was important in reducing mortality and morbidity as well. So in conclusions, patients with a diabetic foot disease are at increased risk for lower extremity amputation and premature mortality. This is something which is a must go. A lot of the physicians will come to us, do an amputation. We do the amputations, yes, but you had increased his mortality rate. This patient has a very high chance to die for unknown reasons. If you want to ask me why, we don't know. So in the setting of chronic infection, significant tissue loss, or an unstable deformity, select patients may benefit from major amputations. However, after a lower extremity amputation, patients with diabetes are 3 times more likely to die within 1 year of surgery compared with patients who have not undergone lower extremity amputations. I usually don't like to write sentences out, and I like to speak them out, but with this I had to. I really had to. This is one of the major conclusions which I said I have to explain it to you so that you could actually grasp it. If I have to repeat it again, then I would have repeated. Patients with diabetes are 3 times more likely to die within 1 year of surgery compared with patients who have not undergone any type of amputation. So the increased risk is not fully explained. We do not know why. Why a patient who is amputated, who's diabetic and amputated, would actually have a very high mortality is still unknown. So another one is also the preservation of lower extremity function is pretty much the primary goal. This is the most important thing, regardless if they had undergone limb salvage or amputation. And reconstructive surgery should strive. So the same patient that I had shown you before, who had a pretty much lateral column overload, with proper post-operative management, he had a good plantigrade foot. The key word here, a plantigrade. You had reduced the amount of pressure sustained onto it. Thank you.
Thank you, Dr. Nasser, for your presentation. It was sweet and short. Please don't kill Hani.
So we're behind on schedule. We'll skip the discussion, and that concludes the vascular session for the morning. We'll move on to the lunch, and we'll plan
before the lunch, I know you guys are hungry. So it was somebody forgot his phone here. So it was a very wonderful session. I really enjoyed it. I enjoyed the lectures. Speakers are very wonderful. Let's conclude the points for the last session, and then we'll go for the lunch. So early referral, if you don't feel a pulse, pedal pulses, to vascular surgeon. Consider non-invasive vascular study as a tool to help you to diagnose peripheral vascular disease. Delay wound healing is indication for vascular referral in 4 to 6 weeks. Endovascular is very effective in limb salvage, is very important. Bypass indicated in certain type of cases. Major amputation, we fight major amputation, but in some cases if there is no functional limb and the patient's life is come first before the limb salvage, if we have to sacrifice the limb in comparison to the patient life. I think this concludes the session. Workshop will start at 2. There is 2 workshops, wound assessment and wound dressing, and diabetic foot assessment and offloading. It will be in the 2nd floor. You guys welcome to go to the workshop at 2, and also at the same time we have the 3rd session for today will start at 2, and you guys free for the lunch and pray time. Thank you so much.
الو هلا ماما. ماكو للحين ما خلصت، شوية واخلص. اوكي يعني يبيلي بعد نص ساعة واخلص واروح المول، فانتوا خلصوا لكم خلصوا. انزين تعالوا، ما تبون تجون؟ اتوقع عندي. ليش تحولي لي شنو؟ انا ما عندي كرت. يعني انتم ما تبون تجون؟ تبون تقعدون بالهذا؟ هي كنا ب350. خلت اشيك، انا كنا عندي. ايه لقيت لكم مكان بالمول، ما رحنا على ولا مرة، كلهم ماركات، وحتى الكافيهات ماركات. أقول لك حتى الكافيهات كشخة اللي موجودة فيه. إذا تبي تروحين تتمشين فيه لبسي كشخة. إيه بنفس المول. أوكي. جاليرية. إيه ماشي. Hello? Ultimately, the goal is to emphasize the importance of this research and improving healthcare in the GCC region. The University of Western Australia organizes that its campus is situated on Noongar land, and that Noongar people in spiritual of their land and continue. I was a lecturer study at the University of Western Australia as well, 14 to acknowledge that the University of Western Australia is situated on Noongar land and the Noongar people of spiritual of the land and they do to practice their values, language, belief, and knowledge. They will begin by exploring the background of diabetic disease in the context of diabetes, highlighting its impact on healthcare systems and individuals. Following this, we'll delve into the research project, overarching question. We'll then address the timeline of the project and its impact. Lastly, we'll conclude with a summary. Let's dive into the background first. The rise of diabetes in prevalence, morbidity, or mortality rates is swift and alarming, with over 500 million people affected, comprising more than 10% of the global adult population. The impact is immense. The gravity of this condition hits hard when we acknowledge that every 7 seconds someone dies due to a diabetes-related complication. Moreover, it has surged to become the leading cause of kidney failure and lower limb amputation. Diabetic foot disease isn't just a complication, it's a severe one, leading to significant health issues and higher mortality and financial strain on both the individual and healthcare systems. Let's delve a bit deeper. Every 20 seconds somewhere across the globe, a person with diabetes undergoes an amputation. The risk for lower limb amputation for someone dealing with diabetes is a staggering 23 times higher than someone without. Now, before we proceed, this is a trigger warning. The upcoming content might be distressing for some people. Diabetic foot disease is more than a medical term. It's a series of issues, it's deformities, ulcers, infections, all linked to nerve and blood vessel problems in the lower limbs. Its impact is huge. It's a key reason for non-traumatic low-limb problems worldwide, leading to hospitalization and amputations. Worse, it worsens heart conditions like coronary artery disease. People with diabetic foot ulcers face a much higher mortality rate than those without. Within a decade, the risk of death doubles for them. Shockingly, the 5-year mortality rates post-foot complications rivals aggressive cancers and severe heart failures. As we can see, progress has been achieved for the 5-year mortality rate. For breast cancer, however, diabetic disease complications have resulted in mortality rates surpassed only by lung cancer. But international dollars don't really truly depict the burden. Treating a foot ulcer might cost 6 days of income in the US, but staggering 5.7 years of income in India. These disparities show a massive economic burden, catching the attention of global groups such as the World Economic Forum, flagging diabetes as a big business risk. In the Middle East and North Africa, it's been evident that it has the highest prevalence of diabetes among all IDF regions, International Diabetes Federation regions, according to the 2021 IDF report. When we zoom into the GCC, nestled within the MENA region, it includes the 6 countries that we all know: Bahrain, Kuwait, Qatar, Saudi Arabia, United Arab Emirates. Their collective population reaches 53. Across Arab nations, we've established that diabetes rates are concerning. However, the GCC nations report the highest prevalence. A retrospective study comparing GCC countries with other MENA nations such as Lebanon, Cyprus, Iraq, Jordan, Palestine, Turkey, Syria, Egypt, Iran, and Yemen supported this alarming trend. The GCC countries showed a higher diabetes prevalence of 24%, surpassing the 16% prevalence of the non-GCC. In the GCC, diabetes is flagged as one of the region's most pressing public health challenges. Over the past 2 decades, the prevalence of diabetes has surged significantly and is projected to skyrocket by 96%. Mute me.
السلام عليكم. يلا الحضور كلهم وصلوا ولا باقي ولا تأخرنا ترى كثير؟ السلام عليكم. لأن تأخرنا
طيب السلام عليكم ورحمة الله وبركاته. We'll come back after lunchtime. So we'll start with the last session, and thank you for your presence at this time. We'll start with the first speaker from UAE, Dr. Sami Tabib. He's originally from Libya, and also he did his training in the US. Please welcome Dr. Sami.
Assalamu alaikum. Shukran, Dr. Hani, for the kind introduction. I'd like to take this opportunity to thank the organizing committee for inviting me to give this presentation. Great conference, great talk so far. So what is diabetic foot syndrome? What's this entity that we're all here for, trying to find a solution for? It is any pathological changes that you see in a patient with diabetes that are related to diabetic complications, which are neuropathy and peripheral vascular disease. These can be pre-ulcerative, such as corns and calluses, can be ulcerative, the ulcer in itself with an infection, can be osteomyelitis, Charcot neuroarthropathy, and then the consequent amputations and comorbidities that follow. And the pathways to an ulceration are similar, but essentially peripheral neuropathy and peripheral vascular disease or peripheral arterial disease are the two factors that lead to a deformed neuropathic foot becoming ulcerated. So diabetic foot syndrome is the consequences of these two diabetes-related complications, peripheral neuropathy and peripheral vascular disease, affecting the lower limb. What neuropathy does is decreases sensation. An insensate foot that is deformed with an abnormal load can ulcerate. These ulcers, in the presence of peripheral vascular disease, may delay in healing, may become infected, and can lead to amputation. So the cascade is, again, neuropathy, ischemia, you have diabetic foot syndrome with a consequent possible ulceration, Charcot, infection, and then the consequent amputation, disability, economic consequences, mortality, poor lifestyle outcome. And the stages of the syndrome are around the turning point of diabetic foot disease, which is the ulceration. So a pre-ulcerative phase is the phase of a neuropathic foot that is at risk of ulceration, and this phase is always around, focuses around trying to prevent the ulcer. In the ulcerative phase, the focus is trying to find a solution to healing, and the post-ulcerative phase focuses on trying to prevent the ulcer from recurring. And as was shown previously, and I will show later with some numbers, diabetic foot ulcers recur with vengeance. First, we go with neuropathy. Quickly, there will be an extensive talk on neuropathy coming up later. Just definition, presence, signs and symptoms of peripheral nerve dysfunction in a diabetic after excluding other causes. And the pathophysiology, I will not go through now. The only thing is the epidemiology. In type 1 diabetics, it's age-related. So it's unlikely for a type 1 diabetic at the time of diagnosis to have neuropathy, as these two studies show. But 15 years from diagnosis, the rate of diabetic peripheral neuropathy in a type 1 diabetic becomes almost par with the type 2 diabetic, which is around, depending on which study you look at, from 25% to 50% in terms of epidemiology in type 2 diabetics. The sensory neuropathy presents in an insidious fashion, glove and stock distribution, has negative sensory symptoms and positive sensory symptoms. The negative symptoms are loss of sensation, numbness, deadness, feeling of wearing gloves and socks, and sometimes feeling of imbalance. And the positive sensory symptoms we are all familiar with, the burning, pins and needles, tingling, and sometimes hyperesthesia. Neurologic exam, from our point of view, should always be looking for loss of protective sensation. Loss of protective sensation, the insensate foot is the one that's prone to ulceration. And screening should be performed for all type 2 diabetics at the time of diagnosis, and 5 years after the diagnosis of a type 1 diabetic, and assessing vibratory, touch, pressure sensation, any of these two together is quite sensitive in detecting DPN. These patients who have loss of protective sensation should be risk managed aggressively. These patients are at risk of ulceration, and they should be, number one, educated on how to substitute this loss of protective sensation with other modalities, be it palpation, be it visual inspection. They should be put in the proper footwear to prevent the ulceration, and they should be seen regularly in a diabetic foot clinic to detect pre-ulcerative changes that precede all ulcers. Peripheral arterial disease is the second comorbidity that leads to diabetic foot syndrome, and this is the atherosclerotic occlusive disease of lower extremity that the last session was about, so I will not go extensively into this, but it is a marker for atherosclerosis in other vascular beds, be it cardiac, cerebral, or renal. And the epidemiology, 20% of diabetics will have an abnormal ABI, and the nature of peripheral arterial disease in diabetics is different. It is more diffuse compared to the focal disease seen in non-diabetics, and it's predominantly below knee. Presentation in the milder cases presents as intermittent claudication, where pain is reproduced upon walking a certain distance in the buttocks, calf, thighs, and sometimes even the plantar foot, and then relieved by rest and reproduced. More extreme presentations are the critical limb ischemia symptoms that can be rest pain, tissue loss, or gangrene. Ankle brachial index is a very useful bedside modality to diagnose or at least screen for peripheral disease, where we measure the systolic ankle pressure and compare it to the brachial ankle pressure, and the numbers should be 1, they should be the same. A lower ankle pressure indicates peripheral vascular disease, and a high ankle pressure, a high ankle brachial index can also indicate calcification in non-compressible vessels. And it is quite sensitive and specific in detecting peripheral arterial disease. And the recommendation is every diabetic over the age of 50 should be screened for peripheral arterial disease, and those with comorbidities even below the age of 50. And anyone with positive symptoms, of course, should be referred to the specialist. A quick word about deformity. So we have peripheral neuropathy and we have peripheral vascular disease. Deformity, motor neuropathy causes deformity in the feet, and these deformities cause areas of abnormal load. In a non-neuropathic patient, this is just painful calluses or corns. In the neuropathic patients, these can lead to ulcerations. And an example of claw toes, hammer toes and claw toes are one of the deformities that occur due to motor neuropathy. In this case, the patient is actually walking on the nails. The dorsal ulcer is actually technically plantar. Then we come to the ulceration point, the turning point of diabetic foot syndrome, where, as mentioned earlier, the majority of these ulcers have a neuropathic component to them. The epidemiology is the prevalence rate 5 to 9%, depending on the cohort. And the majority have, as I mentioned, a neuropathic influence. 86% in these of patients with ulcers were found to have neuropathy. 42% were found to have peripheral vascular disease, peripheral arterial disease. Recurrence. So ulcerations in diabetics recur. 40% at 1 year, 60% at 3 years, 65% at 5 years. It is useful to name a healed ulcer, a patient with a healed ulcer, as a patient in remission, as suggested by Armstrong et al. Instead of cured. This manages the expectations of the patients better, because patients, when they have a recurred ulcer, will blame the clinic, will blame the physician as a failure, because they do not expect it to recur. And patients should know that it will recur if left if managed poorly. Then the next complication in diabetic foot syndrome is Charcot-neuroarthropathy, where you have damage, destruction of joints due to neuropathy, particularly in the midfoot. The prevalence rates are as noted, and it is critical that every warm, red, swollen foot should be considered Charcot until proven otherwise. Why is that the case? Because we are trying to prevent deformity. So if Charcot is diagnosed, it needs to be immobilized immediately. If you do not immobilize it, it will deform, as seen here in this midfoot collapse. These midfoot collapses lead to the midfoot Charcot ulcers that have a much higher rate of ulceration. 37% of Charcot patients who end up with deformity end up with ulcerations. So we're trying to develop to prevent deformity in patients who have Charcot. And the risk of amputation in patients who have Charcot with deformity versus patients who have Charcot without deformity, 7-fold higher. So Charcot, when diagnosed earlier, immobilized, you actually reduce rates of amputation. And treatment is simple immobilization, many techniques to that, until the temperature normalizes, swelling subsides, goes into the coalescence stage, which can take up 6 to 9 months. It's a long period of immobilization. These ulcers in a diabetic foot syndrome can get infected. As much as 50 to 60% of ulcerations can become infected, and infection increases morbidity and mortality. Ulcer infections, diabetic foot infections, are a major cause of hospital admissions and readmissions. These infected ulcers can lead to osteomyelitis, and osteomyelitis is more common than we think, where a soft tissue infection can seep into the cortex of the bone and then into the bone marrow and cause infection in the bone. And osteomyelitis should be suspected in all ulcers that keep recurring and ulcers that are not healing. And as much as 20% of ulcers by cultures have osteomyelitis. The diagnosis is obviously clinical, laboratory, microbiological, and radiological evaluation, sometimes biopsy. Diabetic foot syndrome leads to amputation. So we've gone through all of this. What does it do at the end? It causes amputations, and the numbers are staggering right now. A non-diabetic, a diabetic is 23 times more likely to undergo an amputation compared to a non-diabetic. It also causes people to die. Mortality rates, 5-year mortality rates are comparable to many cancers. With Charcot, you see it at around 30%. With the diabetic foot ulcer, same. And then if you have a minor or major amputation, 5-year mortality rate goes to almost 50%. And it is the mortality rate with a diabetic foot ulcer is 2.5 times compared to a diabetic with no ulcer. Please let me know, Hani, if I'm behind. I'm almost done. Then the diabetic foot syndrome causes an economic stress on society. In this study in 2014, 1% of the expenditure in England was on diabetic foot management. In summary, diabetic foot syndrome is a devastating pathology. Neuropathy and peripheral arterial disease lead to ulcerations. These ulcerations can get infected, lead to amputation. Charcot can also lead to amputations, and that's why diabetic foot syndrome remains a major public health problem. Thank you.
Thank you, Sami, for making it easy for us and you break through the diabetic foot syndrome. The second speaker, again, Professor Wala Khalifa from Egypt. She will talk about tight control of diabetes and diabetic foot complication. Please welcome Professor Wala.
Bismillah ar-Rahman ar-Rahim. I will speak now for my main mission. And this is the main mission of diabetologists, is the control of diabetes. And diabetes is a disease of complication. And all diabetologists focusing on cardiovascular complication mainly because of mortality and food. It is not or neglected until there is a big problem. So we speak about tight control of diabetes and diabetic food complication. This is my disclosure, I have no conflict. This is my agenda. I will speak about the impact of hyperglycemia on food complication and long-term outcome of intensive glycemic control and the effect of hyperglycemia on diabetic foot ulcer occurrence, healing, and recurrence, and explore different studies to evaluate the association between glycemic control and the outcome, and finally analyze the impact of various diabetes medication on diabetic foot outcome. First of all, we know that diabetic foot problem is diverse. And from the beginning of this conference, many lectures analyze that diabetic foot start with neuropathy, which is the main pathophysiology for diabetes, with loss of protective sensation, and also motor neuropathy with deformities and increased pressure areas. This all make diabetic foot ulceration. Also, there is a history of ischemia, or one of the macrovascular complications of diabetes is a peripheral arterial disease, and ischemia can lead to increased risk of infection and gangrene and what else. So if we said diabetic foot, you can see all of these things as a diabetic foot complication. Diabetes as a state of hyperglycemia make a very important litigious effect on the endothelial. As diabetes, the main complication start with endothelial dysfunction. That is why we say the diabetes complication is mainly vascular, either microvascular or macrovascular complication due to endothelial dysfunction, with consequently this complication due to increased reactive oxygen species and increased oxidative stress, which all resulted in complication. After endothelial dysfunction, you see microvascular complication and neuropathy, one of the microvascular complication. And then if we proceed to macrovascular complication with BED and ischemia, this resulted in increase in risk of ulceration, delay in wound healing, and also increase of the risk of infection. Don't forget in neuroarthropathy or Charcot-Foot, and Charcot-Foot before said that they say that Charcot-Foot diagnosis is a diagnosis of experience, as Charcot-Foot is there is not good tool for diagnosis of a Charcot-Foot, and also MRI in the early stages cannot differentiate between Charcot-Foot and osteomyelitis, so you're facing a problem in early diagnosis of Charcot-Foot. And also in diabetes, there is impaired immunity with impaired wound healing and increased risk of infection. So hyperglycemia is a main enemy and for diabetic foot pathophysiology. So what is tight glycemic control? Tight glycemic control ranges from different guidelines. And we see the NICE guidelines and the ADA guidelines. The NICE guidelines are more strict, and they said that tight glycemic control mean hemoglobin A1C less than 60.5. But actually, when we reach this target, we see very high symptoms of hypoglycemia, especially within the elderly, which may increase the risk of cognitive dysfunction and also increase the cardiovascular risk, which then appear in accurate study, or patients who have tight glycemic control increase in the cardiovascular mortality due to arrhythmia and ischemia. So we all respect the American Diabetes Association, and she is the main guidelines we take about, and they said that ADA, that tight glycemic control mean hemoglobin A1C less than 7%. Glycemic control and the impact of complication. There are many studies that analyze the effect of early intensification of diabetes treatment and its outcome on the diabetic foot complication. This study starts with the United Kingdom prospective study, UKBDS, which analyze the early intensification in naive type 2 diabetes and its outcome on the diabetic complication. Also, DCCT trial and on the type 1 diabetes, Accord Advance, all of these trial in patients with diabetes all agree that early intensification of diabetes prevent complication. But the prevention of complication is not equal in all cases, as early intensification is very important in the reduction of microvascular complication, while in cardiovascular there is significant reduction, but actually there is reduction, but actually it is not significant, and some cases still have remnant cardiovascular complication despite they have glycemic control. Also, cardiovascular mortality is not affected by tight glycemic control, and in Accord study, they astonished that there is increased risk of mortality in patients with tight glycemic control. This make the ADA guidelines to make individualized target to patients with diabetes. So I cannot tell every patient that you must have tight glycemic control. Some patients we have lost glycemic control, especially in elderly patients, especially in patients with high risk of hypoglycemia, in less motivated patient with severe comorbid condition, and in low resources. All of these, I can lose glycemic control up to 8%. But the UKPDS said a very important word. They said that every 1% reduction in hemoglobin A1C results in 43% reduction in the risk of amputation. So every 1% reduction in A1C results in more than a third of cases decrease the risk of amputation. And glycemic control is one of the most important pillars in the management of diabetic foot ulcer. Not also, we know that diabetic foot ulcer, debridement of loading and revascularization, but glycemic control is very essential also. So hyperglycemia also affects wound healing by increased inflammatory cytokines and increased tumor necrosis factor alpha, and all make abnormal fibroblasts with bad healing. Also, accumulation of advanced glycation end product in the extracellular matrix prevent wound healing. So hyperglycemia can affect the healing of the wound. Hyperglycemia also impairs wound healing by many mechanisms. This is the first study that studies the association of hemoglobin A1C and wound healing in patients with diabetic foot ulcer. And this is a retrospective analysis of 27% of participants and about 500 diabetic foot ulcers. And they conclude that there is no association between hemoglobin A1C and the wound healing. And this was an astonished conclusion. So they recommend to do another further studies as these results. I think it is not logic. Another important study, which is the EJOFI study, and this study also studies the association between A1C reduction and the healing of diabetic foot ulcer, and they conclude there is a positive correlation between hemoglobin A1C reduction and the rate of healing of diabetic foot ulcers. Armstrong put a meta-analysis of 60 observational study to study the effect of glycemic control and the diabetic foot ulcer outcome, and this meta-analysis concludes that patients with higher hemoglobin A1C have higher tendency to amputation. Also, there is a delay in wound healing and increase in unhealed ulcers in patients with poor glycemic control. So he concludes that patients with A1C more than 8% are associated with increased likelihood of lower extremity amputation and unhealed diabetic foot ulcer. Another important and recent study about the intensive glycemic control and its effect on the healing of the diabetic foot ulcer, which is called the feasibility study. And also they include there is evidence of moderate quality that tight glycemic control may be beneficial for ulcer healing. So we can conclude that early intensification of diabetes is very essential. Not also, we cannot say that intensification is important, but early intensification is important. Why I say that? Because early intensification prevent what's called the metabolic memory. As patients with diabetes in early stages have a risk of endothelial dysfunction. If you have tight glycemic control, you will prevent this complication. But after the complication begins, the cascade still continue, but intensification delays the progress of this. So we all seek to early intensification, and now there a tendency towards early combination treatment versus monotherapy to delay the inertia that occurs in people with type 2 diabetes and to prevent the metabolic memory. So what about the diabetes medication? Is there any effect on the healing of diabetic foot ulcer? First, we study the effect of metformin, which is metformin is the king of diabetes management, as it is an insulin sensitizer, and metformin shows that they have improved the wound healing by modulating the microenvironmental fibroblast and the macrophage. So if your patient is controlled in metformin and have diabetic foot ulcer, you can continue on metformin treatment, and there is a beneficial effect, no hazard effect. Another type of medication which is called DB4 inhibitors, and one of the DB4 inhibitors is vildagliptin, and vildagliptin efficacy and safety in patients with diabetic foot ulcers. A big study concludes that vildagliptin treatment effective in healing of diabetic foot ulcers and associated with reduction in inflammatory biomarkers. Also, DB4 recommends that they are the preferred option in treating of diabetic foot ulcers. As we said before, that the DB4 was the recommended treatment in patients with COVID, if you remember, and because DB4 is a very safe, no risk of any complication, but also they show that it is have a good insight on diabetic foot ulcer healing. Now we speak about sodium glucose cotransporter inhibitors. This is a unique molecule for the management of diabetes. This recent molecule acts on management of diabetes by a unique mechanism by increasing the excretion of glucose in urine. This molecule makes a role in the management of diabetes, so we can manage diabetes without pancreatic function, to delay insulin intensification in some patients. And this molecule have also a cardiovascular and renal protective mechanism. So this not only a treatment for diabetes, it is also has FDA approval for the management of patients of cardiovascular disease, heart failure, and patients with chronic kidney disease. But unfortunately, in Canvas study on canagliflozin, which is one of the SGLT2 inhibitors, they see a higher risk of amputation. And this make FDA a warning regarding using canagliflozin in patients with diabetic foot. This make canagliflozin to be step back in the management of diabetes, and this debate resulted in someone said that it is a class effect, and the other said it is a molecule effect. As SGLT2, it is not only canagliflozin, we have empagliflozin and also dapagliflozin. And in empareg on dapagliflozin, no notice any increase in the risk of amputation. Also in the dapagliflozin declared TEMI study, there is no risk of amputation. It is only observed in Canvas study. So FDA make its warning on canagliflozin only. Another study in China also on the canagliflozin and the effect on the risk of amputation, and they also agree that patients on canagliflozin have higher risk of amputation. So before you heal your patient with diabetic foot ulcers, please you can repeat his medication, revise every medication and the hazardous effect on diabetic foot ulceration. And at this time, we recommend that you must stop SGLT2 inhibitors, whatever cana, empa, or dapagliflozin. And this study also shows that increase the risk of amputation. They try to make an analysis. Why is this risk of amputation is observed in these types of medication, which are the marvelous medication now in the management of diabetes? And some theories, they said that the diuretic induced hypovolemia, and they make diuresis and natriuresis. So patient with poor oral intake, with dehydration, with lower limb ischemia may aggravate this ischemia. So take care of patient taking SGLT2 if he have a food problem. Insulin still is a mainstay treatment for patients with diabetic foot wound, but you must not rushing on insulin. Insulin have a beneficial effect as it can control blood glucose earlier, especially in patients with diabetic foot infection. But insulin also have some hazards. It may promote salt and water retention, promote weight gain. So if your patient is not in need for insulin, there is no need. But all studies done on insulin, they recommend that using insulin patient with diabetic foot ulcers and diabetic foot infection is very important in early controlling of the blood glucose. Also, insulin have increasing growth factors, so increase the rate of healing in patient with diabetic foot ulcers. And some studies done on topical or injection of insulin inside the ulcer and shows that insulin increases growth factor and increases the healing rate. But we can say that insulin is mandatory in cases of diabetic foot infection. As diabetic foot infection, most of people have increase in the counter-regulatory hormone, increase in glucagon level, so they have a state of hyperglycemia that not responding to any types of oral medication. So in this case, we recommend insulin to early control of hyperglycemia and consequently improve eradication of infection. So my key message is glycemic control is essential, but don't forget that early intensification is the most essential. Not to delay intensification, please. As delay intensification, you go to complication, and after that, you just delay the complication, but not to prevent the complication. And all the studies and meta-analysis conclude that glycemic control is essential in wound healing and the prevention of all types of diabetic foot complication. Regarding medication, you must revise the medication treatment with your patient, and vildagliptin, metformin have a beneficial effect, while SGLT2 inhibitors, please stop in any patient with diabetic foot problem. And insulin therapy is essential to early control of diabetes, especially in patients with diabetic foot infection. Insulin therapy is mandatory. And thank you.
Thank you. Thank you, showing the importance of controlling diabetes to increase the healing of diabetic foot ulcers. We'll go to the next speaker to talk about education and education in diabetic foot. We'll call Maha. Maha?
We'll go to the, Maha, she should be around. So we'll go to the next lecture. Dr. Basim Al-Malki is a consultant diabetologist from Taif. He will talk about diabetic neuropathy.
Dr. Basim is a long friend of us in Diabetic Center and diabetes.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon, everybody. First of all, I would like to thank the organizing committee for invitation and for giving me the chance today to talk about diabetic neuropathy. So at the beginning, during my talk, I'm going to talk about this points: introduction, disease epidemiology, risk factors, pathophysiology of diabetic neuropathy, classification, diagnosis, and then overview about management, and lastly, conclusion. So, as a definition, Diabetic neuropathy is a nerve disorder which is found in patients who have a diabetes or simply damage to nerve in peripheral nervous system. As epidemiology, the true prevalence is actually not known, and it's depend on the criteria and method used to define the neuropathy. Actually, from several large studies, approximately 50% of patients with diabetes will develop neuropathy, which is high percent. From landmark study, they defined neuropathy as a decreased sensation in the feet and depressed or absent of ankle reflexes. And they found around 50% of patients had neuropathy. According to UKBDS trial, actually they found more than 35% of diabetic patients, they have neuropathy. This is local study done in Al-Madinah Munawwara. In our kingdom, the prevalence of diabetes more than 47%. This is some statistics. Half of all limb amputations are caused by diabetes. Neuropathy increases the risk of amputation, especially if there is a deformity or a previous history of foot ulceration. 70% of people die 5 years following an amputation. 85% of all amputations begin with an ulcer. More than 50% of all amputations can be prevented in case of tight glucose control. Now, this is about risk factors. The most common risk factor is uncontrolled diabetes for long durations. The other risk factors like damage to blood vessels, injury to nerves, autoimmune factors. Sometimes you may have a patient with well-controlled diabetes and at the same time he has diabetic complications, neuropathy one of them. So in such cases, genetic factors should be considered. The other risk factors, lifestyle factors like smoking, diet, and alcohol ingestion. So, about pathophysiology of diabetic neuropathy, actually it's not clearly understood because there are many factors affecting at the same way. Actually, in case of normoglycemia, the glucose, it will be metabolized to glycolysis through mitochondria to produce an ATP. In case of hyperglycemia, the excess blood glucose, it will be metabolized through polyol pathway and it will produce sorbitol, which is pathogen to the nerves. So, as a summary, we can say hyperglycemia, through many pathways, it will cause diabetic neuropathy. The effects of the mentioned pathway, it will be directly on the blood vessels, micro blood vessels and blood capillary. So if the blood capillary affected, the blood supply to the nerves, it will be decreased, and at this time the nerve pathology, it will be started. As a complication, so ulcers, Charcot, foot, stress fracture, and amputation. This is classification of diabetic neuropathy. So we have sensory neuropathy, motor neuropathy, and autonomic. Sensory neuropathy, because of loss of sensation, there will be loss of pain significantly and increased risk of ulcer. In motor neuropathy, there will be decrease or poor nerve supply to the muscles, and this will lead to deformity and increased risk of ulcer. And finally, autonomic neuropathy, there will be absence of sweating, and there will be anhidrosis and can lead to callus formation and fissures. This is an example to sensory nerve injury. So sensory, we have large fibers and small fibers. Large fiber is responsible for vibration, proprioception, and reflexes. Small fiber, it's responsible for pain and temperature. Again, this is an example for motor nerves, which is responsible for muscle wasting, hypotonia, weakness, and hyporeflexia. Autonomic nerves, there will be decreased sweating, hypotension, urinary retention, and impotence. So, to diagnose diabetic neuropathy, we have to go through these steps. First of all, from clinical history, the symptoms like numbness, tingling, painful sensation, and from physical examination, the signs, the common signs, the loss of reflexes, decreased sensation, joint deformity, and skin changes. Perception measures like sensory testing, vibration threshold, cold and heat threshold. Finally, we can do some measures like nerve conduction studies. About management, the gold standard way to manage diabetic neuropathy is tight glycemic control. The other ways of management is only symptomatic treatment to decrease the pain. Actually, intensive glycemic control, it significantly decrease the neuropathy and the complications from neuropathy. Again, intensified therapy, it is significantly decrease neuropathy. Okay, for prevention, this is the daily food care guide for people with diabetes as an educational tool. So we can instruct the patient to wash the feet, dry after that, nail care, never walk barefoot, and choose a proper type of shoes, and so on. As a conclusion, diabetic neuropathy is a common. Tight control can prevent neuropathy. Presence of neuropathy can severely affect quality of life. Once a patient develops neuropathy, there are a few treatments proven to be effective. Food care is essential in preventing neuropathic complications. And thank you.
Thank you, Dr. Basim, for your presentation. Second speaker is going to be Abdurrahman Sagabi. He's a consultant diabetic foot surgeon, fellow trained with Dr. Lazaro. Please welcome Dr. Abdurrahman.
Assalamu alaikum wa rahmatullahi wa barakatuh. My topic today, I will be speaking about setting up diabetic foot clinic in your center. So first of all, to start with, limb loss is one of the most devastating complications of diabetes and represent enormous burden on individuals, their families, on health system in general. So reducing the number of diabetes-related amputation is a major goal of Ministry of Health, and to achieve that, patients need to receive the right foot care at the right time by the right team in the right place. So how we can determine that? You have, at the beginning, you determine the patient risk level and the service needed. So each center should know their capabilities and what they can provide for the patient and what does the patient need. Does the patient need to be seen by surgeon, podiatrist, or only by GP? So each level of service in the healthcare system, starting from primary healthcare centers to specialized diabetic centers, ending with diabetic foot centers and tertiary hospital, which has multidisciplinary team for diabetic foot. Based on that, determining the patient level of risk and early referral to the right service is very important in achieving desired outcome. So if we go for the risk classification of diabetic foot, we have low, moderate, high risk, and patient in remission and active foot disease. For the low risk patient can be followed annually by general practitioner or diabetologist. And for the moderate risk patient, also they should be seen annually by by a podiatrist or diabetic foot team. And for the high risk patient should be seen every 6 months. And for the patient who is in remission, who have previous ulcers, need frequent follow-up like 3 to 6 months. Patient with active foot disease who have current ulcer or has active infection need to be seen immediately within 24 hours for early intervention. So what are the different levels of diabetic foot surface in the healthcare system? As we mentioned, we have primary healthcare centers, we have diabetic centers. Most of the region now have diabetic centers, and in our region, Al Qasim, we started specialized diabetic foot centers, which is tertiary center dealing with active disease and patient with different level of risk. Or patient can be seen in emergency department for further intervention and management. So if the patient is living well with a chronic disease, or patient is low risk patient or moderate risk, can be seen at primary health care or seen by diabetologists and diabetic centers. If you go further with the risk, patient should be seen by more specialized team as a multidisciplinary team, reviewing their vascular status, reviewing their deformity, and determining the level of risk, and do the further management as a protection, as a level of protection. So what are the services at the primary health care, which is usually provided by general practitioner and family physician? The model of care in primary health care center for diabetic patients include the primary and secondary prevention for diabetic foot patient. All health care providers involved in managing diabetic patients will support people to have awareness of their risk and empower them to make healthier choices. They are responsible for initial foot screening and the classification of the risk and referral for higher service if needed. So that's the primary and secondary prevention, which should be done at the primary healthcare centers by GPs or family physician. Okay. The next level is service at diabetic centers, or community hospitals. Okay, which is secondary level of care. Each diabetic center should build their own photo protection team, which is composed of diabetologist, dietitian, and nurse with the training in diabetes and diabetic care, along with podiatrists to manage moderate, high risk and patient in remission, and collaborate with tertiary center and multidisciplinary diabetic foot disease team there. So they can arrange the plan between them, so for early intervention and prevent further damage for the patient. So each clinic needs to be equipped with some of the materials to diagnose peripheral vascular disease, neuropathy, and foot ulcers, like monofilament or tuning fork, and hand Doppler ultrasound, and some advanced wound care products, not only simple dressing with saline or betadine as old school fashion. Service at specialized centers for diabetic foot, which is tertiary level of care. This is what should build a multidisciplinary team that involved in managing the patient. It's not a one-man show, because it should be done by surgeons. We will go for the specialty which is needed. But as we mentioned, diabetic foot does not belong to anyone. As Dr. Nasser, he mentioned, it's an orphan. Because if you go to region, and even in Saudi Arabia, if you go to Riyadh, you see there is some orthopedics, they are dealing with diabetic foot, some general surgeons, some vascular. So it's not a specialty by its own, okay? So sharing a plan with each team can improve the outcome of the patient. So the team are based primarily in the hospital and specialized diabetic foot centers to provide surgical and non-surgical management of active diabetic foot disease, including wound debridement, revascularization surgeries, corrective or prophylactic, and urgent surgeries, and arrange with photoprotection team for further care of plan. So if you have patient and it's managed at tertiary level, like diabetic foot centers or hospitals, so after that, when patients go in remission, you can downgrade him and be followed by the other team. So, and they will be communicating between each other. So if the patient develops any complication later, he will be upgraded again for tertiary level. So the team should be include, but not limited to, consultant surgeon with experience and interest in diabetic foot, because not every surgeon is willing to follow patient 3 times, 4 times weekly, to do dressing for the patient, debride every time, wait and see. Most of them, they are busy with, they want fast outcome, so they are not passionate with the patient. Okay, consultant vascular surgeon, if needed any intervention from vascular surgery, endocrinologist for diabetic control, dietitian for patient education, physiotherapist, and if there is done any intervention that need rehabilitation for the patient, wound care nurse, podiatrist, because they play a very important role in early detection and management and involve in making a plan for the patients, orthotist for post-operative management or corrective or prophylactic insoles and these things, infectious disease consultant, psychologist for psychological support, social workers and assistant service, labs and radiology department. That's all. Thank you very much.
Thank you. We'll go to the next speaker now, Mariam Al-Isa. She will talk an online talk. She is a podiatrist in Kuwait.
Hello? Can you hear me?
Start now.
I can start? Okay. Hello, everyone. It's a privilege to be here. I'm sorry I couldn't be with you in person, but hopefully that gives me the privilege of having an extra 5 minutes for my presentation. Today we're all here to discuss a critical healthcare concern, which is diabetic foot disease and lower limb amputations in the Gulf. I'm going to be discussing my research in this field in the Gulf Cooperation Council countries. Ultimately, the goal is to emphasize the importance of this research in improving healthcare in the GCC region. I work and I study in the University of Western Australia, so I'd like to acknowledge that its campus is situated on Noongar land and that the Noongar people remain the spiritual and cultural custodians of their land and continue to practice their values, languages, beliefs, and knowledge. Now, today we'll begin by exploring the background of foot disease in the context of diabetes, highlighting its impact on healthcare systems and individuals. Following this, we'll delve into the research project and the overarching question. We will then address the timeline of the project and its impact. Lastly, we'll conclude with a summary. Before we start, there's no research without a team, and I'd like to acknowledge my team, which is a team of supervisors. There are 5 members: Professor Rhonda Clifford, Associate Professor Kevin Murray, Dr. Deb Shawn, Dr. Barbara Natabi, and Dr. Hassam Yunus, who's with you today. Let's delve into first the background of diabetic foot disease. The rise of diabetes in prevalence, morbidity, and mortality rates is swift and alarming, with over 500 million people affected, comprising of more than 10% of the global adult population. So the impact is immense. The gravity of this condition hits hard when we acknowledge that every 7 seconds, someone dies due to a diabetes-related complication. Moreover, it has surged to become the leading cause of kidney failure and lower limb amputations. Diabetic foot disease isn't just a complication, as we all know, it's a severe one, leading to significant health issues, higher mortality rates, and financial strain on both the individuals and the healthcare systems. Let's delve a bit deeper. Every 20 seconds, somewhere across the globe, a person with diabetes undergoes an amputation. And one of my colleagues already mentioned that the risk of a lower limb amputation for someone with diabetes is a staggering 23 times higher than someone without. Now, before we proceed, this is just a trigger warning. If you find any of the images distressing, please look away. Now, diabetic foot disease is more than a medical term. It's a series of issues. It's deformities, ulcers, infections, and they're linked to nerve and blood vessel problems in the lower limb. The impact is huge. It's a key reason for non-traumatic lower limb problems worldwide, leading to hospitalization and amputations. Worse, recent research has found that it worsens heart conditions like coronary artery disease. So people with diabetic foot ulcers face a much higher mortality rate than those without. Within a decade, as someone previously mentioned, the risk of death doubles for them. Shockingly, the 5-year mortality rates post-foot complications rivals those of aggressive cancers or severe heart failure. As we can see from the graph, progress has been achieved in reducing the 5-year mortality rates for breast cancer. However, diabetic foot disease complications have resulted in mortality rates surpassed only by lung cancer. And when we talk about burden, international dollars don't truly depict the burden. Treating a foot ulcer might cost 6 days of income in the United States, for example, but it would cost 5.7 years of income in India. These disparities show a massive economic burden catching the attention of global groups like the World Economic Forum, which have flagged diabetes as a big business risk. Now, in the Middle East and North Africa, the International Diabetes Federation has found that it has the highest prevalence of diabetes amongst all IDF regions, according to the 2021 IDF report. When we zoom into the GCC, which is nestled within the MENA region, it includes the 6 countries that we all know: Bahrain, Kuwait, Oman, Qatar, Saudi Arabia, and the United Arab Emirates. Their collective population reaches 53 million. Across the Arab nations, we've established that diabetes rates are concerning. However, GCC nations record the highest prevalence of diabetes. A retrospective study comparing GCC countries with other MENA nations, such as Lebanon, Iraq, Cyprus, Jordan, Palestine, Turkey, Syria, Egypt, Iran, and Yemen, supported this alarming trend. The GCC countries showed a higher diabetes prevalence of 24%, surpassing the 16% prevalence in non-GCC nations. In the GCC, diabetes is flagged as one of the region's most pressing public health challenges. Over the past 2 decades, the prevalence of diabetes has surged significantly and is projected to skyrocket by 96% by 2035. So that means almost everyone would have diabetes by 2035. The citizens of GCC and Arab residents with diabetes, regardless of their religion, face unique cultural and traditional barriers to foot care that put them at greater risk of diabetic foot disease. They use complementary and alternative medicine, which is still very common, alongside seeking advice and treatment from herbalists to heal gangrene and attending traditional healers for cautery and bloodletting. Alarming figures available from primary healthcare clinics in the UAE paint a concerning picture. Approximately 15% of adults have undiagnosed diabetes. What's even more troubling that there's a staggering 72% of patients with diabetes in the UAE that lack access to crucial foot care, signaling a notable gap in healthcare delivery. And the figure that we've seen just now shows that each GCC country reports a higher prevalence of diabetes in adults compared to the global rates outlined in this graph. Everyone knows that the GCC shares similar traits, including healthcare systems and history of economic growth and urbanization. Now, these transformations have triggered lifestyle shifts, notably an uptick in obesity and non-communicable diseases such as diabetes. Now, if obesity rates were to plateau, projections indicate that the prevalence of diabetes in the GCC countries will persist in an upward trajectory. Despite the increasing burden of diabetes and its complications, such as diabetic foot disease in the GCC countries, we have critical knowledge of gaps which still persist regarding its prevalence, trends, and management. Furthermore, healthcare systems in these nations have yet to adapt to the growing burden of diabetes, resulting in suboptimal diabetic care and its complication management. This underscores the urgent need for more research and healthcare system enhancement to tackle this significant public health concern. So, my PhD aims to tackle a critical inquiry. What are the burdens, trends, and care gaps related to diabetic foot disease and lower limb amputations in the GCC countries? The research is mainly going to be conducted at Cleveland Clinic Abu Dhabi, where I have the support of my external supervisor, who is also the chairman of the Vascular Surgery Department, Dr. Hussam Yunus, who established a multidisciplinary team consisting of vascular surgeons, surgical podiatrists, wound care nurses, vascular technologists, and other healthcare professionals. This team is going to be the backbone of our investigative approach. Our research is focusing on diabetic foot disease in the GCC countries and will involve a series of interlinked studies. Study 1 will be reviewing the existing literature to understand the current diabetic foot disease practices. Study 2 will be analyzing admissions and amputation trends to assess the diabetic foot disease burden. Study 3 will be identifying the risk factors contributing to diabetic foot disease. And Study 4 will be evaluating the multidisciplinary team's impact on the diabetic foot disease outcomes. To accomplish this, we are creating a data set for studies 2, 3, and 4 from Cleveland Clinic Abu Dhabi's EPIC online system. We're going to incorporate socio-demographic data and clinical histories and comorbidities, and we're going to align them with global guidelines such as the International Working Group of the Diabetic Foot and the Society of Vascular Surgery for standardized benchmarking, analysis, and comparison. Study 1 is a scoping review that aims to assess the management of diabetic foot disease across different healthcare settings in the GCC countries. We're going to follow the Joanna Briggs Institute protocol and the PRISMA screening checklist. A thorough search strategy has already been formed, which will span multiple bilingual databases and gray literature sources in Arabic and English, since I'm proficient in both. The study will include studies with individuals with diabetic foot disease, and it encompasses research which is published and unpublished from 1981 onwards. This is a milestone year as it marked the establishment of the first MDT diabetic foot clinic at King's College London by Mike Edmonds. And the data extraction tool that we've developed is adapted from Jess Coates' seminal paper on reporting standards of studies and papers on prevention and management of foot ulcers and diabetes. Our primary goal for study 2 is to track trends in diabetic foot disease admissions through length of stay and initial as well as recurrent lower limb amputations within this region. However, since Cleveland Clinic Abu Dhabi established one of the first diabetic limb salvage programs in the region, our scope extends beyond Abu Dhabi. We're going to compare these trends not just among Abu Dhabi residents, but also between residents of different emirates that have been admitted to Cleveland Clinic Abu Dhabi, particularly examining these disparities between Abu Dhabi and Dubai and the remaining emirates. We'll be examining a range of data parameters. Our analytical approach involves descriptive statistics and multivariable analysis, aiming to uncover essential differences and trends among various population groups in this region. Our primary goal for study 2 is to track trends in diabetic foot. Oh, that's when it's done, sorry. Study 3 is dedicated to identifying risk factors that contribute to burden of diabetic foot disease within the GCC region. This observational retrospective cohort study will span from 2017 to 2023 and will be conducted at our multi-specialty institute in Abu Dhabi with the aim of providing insights into the unique risk factors and comorbidities associated with admissions and lower limb amputations prevalent in this specific region. Our data analysis methodology will employ descriptive statistics as well and binary logistic regression models. Our goal is to pinpoint the factors that significantly contribute to the burden of diabetic foot disease, especially at a national level, providing pivotal insights for shaping future policies. Study 4 is a quasi-experimental study. It's going to center around major adverse cardiac events and major adverse lower limb events. Studying the trends pre and post the MDT's introduction in June 2019. This information is crucial, especially considering the substantial investment involved in these interventions, and will inform strategic decisions in optimizing patient care. I've completed basic and advanced biostats training, hopefully gaining the confidence and skills in advanced statistical methodologies involved in our studies. For further in-depth analysis, my collaboration with my co-supervisor, Kevin Murray, who specializes in medical statistics, will provide me with valuable guidance and expertise. Now, the inclusion criteria is going to be any adult admitted to CCAD with diabetes and a diabetic foot condition between 2017 to 2023. We're going to exclude anyone without any lower limb condition and anyone that doesn't have a diabetes. We're already seeking ethics from CCAD. Once that's approved, we're going to seek the recognition from the UWA Human Research Ethics Committee. Data collection and maintenance will be done using RedCap, which is a secure web application for managing online databases. And we'll be publishing our work in a series of papers as we progress. Doing this helps other studies and lets our work impact the field sooner. Plus, it gives us feedback from other experts, making our research stronger. So today, from my talk and from my other colleagues' talks, we've established that we're confronting a critical gap in knowledge regarding diabetic foot disease, especially in the GCC countries. So our mission is clear. It's to shed light on this unexplored territory and to bring forth invaluable insights that can transform care and outcome for patients with diabetes. What we're building with this research isn't just a data set. It's a cornerstone for local and regional analysis and benchmarking, a tool that could help us understand and address diabetic foot disease in the GCC region. This research isn't just about numbers, it's about impacting lives, about ensuring that every diabetic patient receives the care that they truly deserve. And to conclude, we addressed a critical concern within the realm of diabetes, the distressing outcomes of lower limb amputations impacting the healthcare and the quality of life. By delving into the records of amputated limbs and related outcomes, we strive to unravel the full scope of diabetic foot disease burden in the GCC region. But our aspirations as a team don't stop there. We're evaluating the influence of multidisciplinary functional outcomes like lower limb amputations and major adverse cardiac events, paving the way for advanced team-based care models. Our ultimate goal is not just about records or evaluations, it's about ensuring enhanced access to top-tier diabetic foot disease care. It's about identifying and bridging the gaps in diabetes management and ensuring every individual receives the care that they truly deserve. This research is a commitment to improving lives and reshaping the landscape of diabetic foot disease care in the GCC region. Thank you very much. And if you have any questions or any criticism that you would like, you can just direct it to my external supervisor, Dr. Hussam Yunus, and we'll be happy to take it on board. Thank you.
Thank you so much. Even we're late, but we are done on time. So we're just going to have 10 to 15 minutes because we didn't give you any chance for questions or discussions. So we have all the speakers. We have Dr. Khalid Idris, we have Mohammed Darawish, we have Dr. Basim Al-Malki, Sami, Dr. Ahmed Sagar, Dr. Nasir, Dr. Mohammed Hatim. You guys, you feel free if you have any questions, any comment. So at the end, we can conclude the summary of this presentation for the today. Please feel free if you have any questions, or we can talk.
Any questions? If no questions, I will ask then. I will start with questions to Dr. Sami. You talk about recurrence and you touch something about recurrence. Sami, yes. And recurrence, what's your, my question is, what we can do to prevent the patient not to have recurrence?
Thank you for the question, Ustad Muhammad. It's, my opinion, from my experience, personal experience, the critical thing is to have a regular diabetic foot clinic where patients are scheduled regularly and develop the habit of going to the diabetic foot clinic, whether they have a pathology or they don't. You know, follow the guidelines of the International Working Group as far as the frequency of the visits, depending on the level of risk, every 3 months, every 1 month, every year, depending on the level of risk. And from my personal experience, patients, if you put them on that schedule, they actually stick to it, and it becomes part of their lifestyle, and it becomes part of their 3 monthly visit, etc. That's the only way. You have to keep them coming. You have to keep them coming, and then you follow the guidelines in terms of what you do in your clinic. But the key to prevent recurrence and to detect early pathology is to have, you have to have the patients in the clinic regularly at the required intervals.
Assalamu alaikum. In my opinion, what I have noticed that most of the cases, they recur from the callosities. And I have seen a very small nidus starting from the callosity and going deep down, and patient does not know because most of the cases, they are neuropathic. So they don't get any pain, and they come to you when there's a weeping wound with a lot of foul-smelling discharge. And in most of the cases, I've seen also that there's a involvement of the phalanges also, osteomyelitis. Thank you so much. So we need to actually guide them regarding the foot care and personal hygiene. Thank you so much.
And recurrence, we have to, I think, set up foot clinic when we talk about the categorizations of diabetic foot patients. We know the categorizations is when the recurrence, it's high-risk patient, when they have ulcer, healed ulcer, or amputation. As recommendation, patient should be seen within 6 weeks. That's, I think, the key to prevent the patient from not to have recurrence ulcer. We are talking about patients who have ulcer already and patients healed. So the key that you have to see the patient as soon as possible, or 6 weeks maximum. I used to say to our patients, if you want to prevent a recurrence, be accessible, reachable, available, knowledgeable. That's you really understand, because if you talk a patient with deformity, or callus, what you say, here there is deformity. When the way he walked, he will develop ulcer by default, because the deformity with the no sensation, he will have callus, break down the skin. The best thing is you have to see him as soon as close. Then to blame the patients, ask him to come to you as soon as possible. When they come as soon as possible, we prevent the ulcers. Anyone to comment on recurrence, or we'll go to next setup?
بسم الله الرحمن الرحيم. عبد الكريم الحميد, military hospital, physical therapist. Actually, I do believe, or do agree whatever you have said, but I think education, either to the patients or to the family, one of the critical points I do believe it will help to minimize, decrease number of recurrency. Family playing a big role and critical role to minimize the complications of the patient, as well as the patient. So I wish if we can stress on education to the patient as well as to his family, it will definitely, I do believe from my clinical experience, it will lead to minimize the effects of the patient, the effects of the complications to the patient as well as the family themselves. Thank you.
We have a lecture for education, but the lecture is not speech. I agree with you, doctor, when you talk about prevention of ulceration before it happens. Honest of the ulcers. Education is important. Recurrence is a different story. Recurrence is patient have ulcer and healed the ulcer, and we want not to have the patient. And we mentioned that patient, he will be remission. What Dr. Sami said, because we didn't treat the etiology of the disease. The disease is there, the neuropathy is there, the deformity example is there. So the most important to this patient, proper footwear, rechecked, the mostly rechecked as soon as possible to this type of patients. We know that data showed Dr. Sami, he said 60% will develop, 40% within a year, 60 within 3 years, 65 within 5 years. Even we give education, by the way, by evidence-based of view, we didn't have clue. We educate the patient, we can prevent him not to have ulcer. We can ask the patient to come as soon as possible to the health provider, and then will the health provider act. But education per se, with the disease there, should be, there is debate in that. Any questions, or go to next steps or next? I would like Dr. Abdulrahman to talk about set up for the clinic. Because what we, I think 2006 or 2008, the theme of World Diabetes Day, the International Diabetes, they talk about set up foot clinic. And it was very good booklet. It was published maybe 2008 about set up foot clinic. And they put 3 programs for that. One program just any clinic or any clinic, just general clinic, and you might do touch in that, and they also talk about second was moderate, and they talk about advanced, like they are doing surgery, charcot, or so. I think, what do you comment in this?
To be honest, there is no clear planning for diabetic patient worldwide. So even in Europe and different countries, patient didn't know where to go and when to go. So starting from community to specialized center in the community service, or a specialized podiatrist covering, or the GB himself who should examine the patient. So when he notices any change, that he can escalate the management. He sends patient for further management. So let's take example in Saudi Arabia here. Patient come with an ulcer, or he do a minor amputation. Patient stay in the hospital for 1 or 2 weeks or whatever. The wound is closed. So after that, what will happen to the patient? Nobody knows. So patient will go home, live his normal life, thinking there is no change in the biomechanics, no risk of re-ulceration. This ulcer or this wound is cured, so I have no risk. So what's missing in the system, that the follow-up is very important. And the follow-up should be done by who? So as we mentioned here, if the patient have previous ulceration, so he's in remission. So you cannot downgrade him to moderate risk. So already he is in a high risk, but in remission. Okay, so he have a high risk for re-ulceration again and again. And if you do a minor amputation, there is an impact of biomechanics. So it's different from first metatarsal to fifth metatarsal, but there is impact. So this means patient should be seen at least 3 to 6 months by a specialized either podiatrist or the diabetic foot team to inspect him to make sure there is no re-ulceration or pre-ulcerative lesions. If you build the system this way, you will have, if the patient gets re-ulceration, he will be detected early without complication. So you do offloading, you do whatever as ulcer management. So patient will be cured and he will continue follow up. But the problem in the system now, so the patient, when he managed, he lost, he come again with further problem, amputation. This is the big issue.
I want to comment, thank you, Doctor. I want to comment, there is a good news for all of you who is looking at prevention of diabetic foot. What's the good news? In 2013 or 2014, there is a very good article published when they talk integrating system. I really like what you said, integrating system. What means integrating systems? Means the patient, now what we're having, what you've touched now, there is a patient comes to outpatient and seen by outpatient team, referred to the hospital team. After the hospital team maybe need inpatients or admission, we are not integrating all the system together. In Germany, when they integrate the system just for pilot studies, they are able to minimize the amputation about 75%. If you talk, was the best amputation done just integrating the system. I used to say, integrating health workers together, you can prevent a lot of diabetic patient or ulceration or early surgery for preventions. We are waiting till to come to you, or waiting to come to me, or when it's finished from me, give to you. After that, where to go with the patient? Where to go really the lost patient? Integrating system, this is one of the best. I think we should really talk as one voice to talk how can we integrate the systems for this. Other one, I will give you simple experience with us. I'm working with diabetic foot mostly now 26 years. If anyone don't know me, my name is Hamad Darwish. I'm working diabetic foot from 1996 with Diabetic Center, with Dr. Rubi'an, with the groups gone up to the last one remains me, maybe soon I will left also. Anyway, what happened? We are observing the patient from Diabetic Center. We have 2 patients per year from Diabetic Center develop ulcer. But those that are not from Diabetic Center, 98% of the total patients seen not from Diabetic Center. So we came to the questions, why Diabetic Center no ulcers? Why they came with ulcer without diabetic center? We discovered we are screening the patient every clinic, every visit in fetal science room, pre-clinic we call it. In neuropathic, we put the neuropathic pathway. When he comes with the neuropathy, we give him a shoes, we give him a creams, we see him every 6 months according to the categorizations. And we be access. What means access? Hotline. If you have a problem, Ahmed, Khala Noura, anytime come to us in foot unit, no barriers. After that, we prevent. But patient referred, we have a lot of problems. A lot of problems because patient comes late and then cure. They go back to Qasim or Najran or Jazan. And when they have problem again, where to come? So integrating system, especially in the diabetic center. If we have the whole diabetic center integrating system or pre-clinic, you can go. Don't go complicate things. Just simple examinations, simple things can prevent the ulcer. Dr. Khalid, you want to comment?
I think what you're referring to is the problem of a government or general health sector, whereas in private we don't have that problem, because we always say you never tell the patient goodbye. You always tell him or her, see you after 1 month, see you after 3 weeks. So it's just a given. We never ever tell the patient go away. Then on the follow-up visit, we assess the keratosis. The doctor there mentioned the keratosis. So we assess the keratosis. During the remission time, our job will be to decrease the keratosis as much as we can. Not only by debridement, I want to stop the keratosis. Worst case scenario, by prophylactic surgery, offloading internally. Definitely, we are working on the shoes. And lately, the last 2-3 years, I've been working a lot with filler, just like the filler that you do in your ladies, or some men do in their lips and their face. So we use filler as well underneath the metatarsal heads and in bony prominences to decrease the pressure. My gauge is the keratosis. I want to stop or eliminate the keratosis by any means possible, and that's how we prevent ulcers from reopening.
I just want to point out, you mentioned regarding preventing or recurrence of an ulcer. I think the main thing that we should think about is prevention of an ulcer. This is the best that we could actually say. I truly believe that if we just follow international guidelines according to diabetic foot screening, just to do diabetic foot screening protocol, which is a simple process, half an hour, no pain, ما في إبر, ما في ألم, ما في عوار. You would know your criteria of developing an ulcer. Hence, after that, you could actually try to prevent it. And even in the meantime, sit down and educate the patient, educate the family members, educate everybody else, just to tell them the importance of actually having the single priority is to control your blood glucose, keep your hemoglobin A1C at below 8, as well as please take parameters. You're neuropathic. You should not get into near hot, hot areas or any cold areas. You should wear shoes and what have you. But I do believe diabetic foot screening is the initial step to reduce the rate of ulcerations in the GCC countries.
Thank you, Doctor. What you said is, would we say same what you said, Doctor, in where we are working diabetic center? So all the patients comes to us. We do screening, we do categorization, and we ask the patient to come if they need to come. Today, I came to you maybe 1 o'clock. I have seen 40 patients, 25% of them preventions. As a screening, as skin and nail, as just assessment. And we tell them, oh, you are okay, we'll see after 6 months, you will have to see after weeks, after 2 weeks. So we do that. But doing this, we are able to reduction of the ulceration in our unit, in our center. But others, they have to do that. So we should, I think, link our patient with centers, with diabetic center, not this. When they are not just working here and there, we didn't have enough surfaces to prevent them. Dr. Sami will comment.
Thank you. So, I have a question for Dr. Khalid. In his presentation, he mentioned, he said the Hajj is the biggest gathering of diabetics. When we send you our diabetics, what do you do with them? Is there education? Is there signage? Don't walk barefoot, don't do this, do that. And during the event, the blessed event, is there any protocols you follow? What happens during a Hajj?
Right. The program has been going on for 18 years. I've been actually with them for 12. Sometimes before Hajj, we send to the Mutawif. Mutawif is the leader that has a group of pilgrims with them. We send them leaflets that they distribute, but that's done on a small scale. We're trying for the Ministry of Health to distribute more information about diabetics. But then there are two organizations, البرنامج الصحي التطوعي للحج and SMAV, that was just signed yesterday. Between the two, we probably have about 1,000 individuals who are in the middle between the Hajjis. And then those 1,000, of course, in the middle of 2 million, they distribute pamphlets, they educate, they sit with the pilgrims and talk with them. So it's not bad, but we can be much better. But we're doing all that we can. And both these organizations are NGOs, non-governmental agencies. Maybe the MOH now will get more involved.
Regarding for the Hajj, as you said, like in Bahrain, like even with the military hospital, like with all the patients, like we go to the Hajj, we educate them regarding to their foot because they're complete neuropathy. For past few years, even after Hajj, I clear my schedule for 1 week. I know all of them are going to come with disaster. Because they said, oh, we have fever, maybe flu after Hajj. But no one's seen the effect, either burn or infected gangrene. I had one patient, imagine how old, 40 years old. Infected gangrene, it came after Hajj, and then we above knee amputation. Completely ischemic, the whole foot is gangrene. 40 years old, above knee amputation. Yeah, no way even to do angio. And that's why we now we start some methods, like we have to educate all of them. Either proper shoes, or you can't walk, get a wheelchair. Don't waste your time, yeah. Just to avoid all those complications. And after Hajj, straight away to come to the clinic. So I have to clear my schedule for 1 week, 1 or 2 weeks, because I know the complication will happen.
My comment is, before patient go to Hajj, you have to do screening. That's the comment. If you do screening, no, I think we should not, as honest or as this, you have to say you are risk, you should not go to Hajj. If you go to Hajj, you have this and this. Informing this, he will take risk. He take it, what you can do. Maybe sometimes they are far away from their centers or theirs, but you have to do, I think even any Hajj, performing Hajj, you have to do screening or medical report before going. If he's ischemic, you should, by ethics, we should not allow him to go to Hajj. But if he go on his own, that's his rights. Any questions, or we'll close?
Thank you so much for your presence. This concludes our day. Tomorrow we'll continue the story. Tomorrow is going to be a full day of great lectures in diabetic foot. So we'll start tomorrow, inshallah, at 8 in the morning. Please be early and go to the bed early today. Thank you.